Good morning. While Brian is setting up, welcome back for day 2 of the Cartilage Course. 2 little announcements. Once we have switched the order somewhat to accommodate flight schedules. Number 2, for your CME credits, you should have received an email or multiple emails from Harvard CME. Please fill those out. They're pretty easy. Just point and click, and then you will get your CME credit. Also, you have the option of getting the course syllabus and the presentations either on a DVD, which personally I don't even have a DVD player anymore, so we also offer emailing it to you via Dropbox. Just email Tim Bryant, the organizer. He should have emailed you. Tim, is that you back there?
Yes, it is.
Which email address?
Sign up at the table, your whatever address you want to send to, or email address. That'll go out about 7 to 10 days. There's no need to email me, and you just need a name, email, we'll take care of all of that.
Good, so just write down your email address, and Tim will take care of you. And now we will be starting out with Dr. Brian Cole. Does it run?
Yeah. Okay. So what we're going to do for this morning is cover some sort of miscellaneous topics. And when it comes to the shoulder and the elbow, there's a lot that I've learned from the knee that's allowed me to take care of some similar type patients in the shoulder, occasionally in the elbow, and share with you some of our changes over time and how we think about managing these patients. The cause of in the shoulder, ironically, is most commonly post-surgical. We occasionally see idiopathic degenerative changes in young people where it's focal, avascular necrosis, very rarely OCD, but the vast majority of people that I see have had previous surgery and intact cartilage after index surgery and then have subsequently developed articular cartilage loss. What we learned in our lab is that there's something vulnerable about the glenohumeral joint compared to the ankle and the knee. And it's much more susceptible to just routine arthroscopy, post-arthroscopic changes. But early on, there were a number of patients who presented. This is the first one that I saw. This is a softball player from Kentucky who had thermal capsulorrhaphy only, did not have a pain pump, and developed condylosis, destruction of the whole joint within about 6 months. And as you can see on the left, her index cartilage was perfect. So one of the things we've learned recently is that there are some presumably protective factors in the glenohumeral joint that are absent relative to the knee and the ankle if you take the same donors. So there's something highly vulnerable about glenohumeral joint cartilage that just doesn't exist in other joints. That case I just showed you led to a number of challenges. Some of them were in the area of litigation, actually, and so it led us to look at sort of the world's literature and case reports across all joints to say, look, are people being accurately classified as having total joint condylosis, and what were the etiologies? And we came up in part for just to have some common semantics, what a definition of condylosis is. And where we're at now is we think it's where there's global rapid cartilage loss within 12 to 18 months. That's typically but not always following a surgical intervention. There were clearly cases where it was idiopathic in the shoulder, but more commonly idiopathic condylosis was seen in the hip and even in the foot and ankle after minor degrees of trauma. It's also important to remember that there is some normal anatomy in the glenohumeral joint, both on the humeral side and the glenoid side, that's normally very thin. So be careful about assigning cartilage damage to somewhere where that's just normal anatomy. So, for example, the central bare spot in the glenoid, and there's obviously a bare area on the humeral head between the supra and infraspinatus, so you don't want to assume that that's abnormal. The first knowledge of the contribution of pain pumps came about in 2007 when Brent Hansen and Charlie Beck published this paper. I remember I was at a meeting, it was a Herodicus meeting, and I don't remember where we were, but he presented this data, and everyone sort of staring at each other saying, I haven't seen this, haven't heard about it. And it was starting to occur in people who were using high-volume pain pumps as post-operative pain management. And he published 12 shoulders in 10 patients, all of whom had 0.25% Marcaine and a large intra-articular pain pump. And then we just had this onslaught of patients in Chicago, and we're well over 100. I haven't updated this slide. The good news is I haven't seen one in almost 8 months that's due to pain pump. So what's happened seems to have happened, and people are no longer using the pain pump in the shoulder, to my knowledge. We became very interested in this because it begged other questions. What happens in the office or even the operating room when you do a single shot of Marcaine, bupivacaine, and so forth? Are we putting our patients at risk? And we found two things. We created a short-term, as an animal model with a pain pump. The short-term model was 48 hours, then sacrifice. Then we did a longer recovery time to see what happens from recovery. And amazingly, the rabbits anyway seemed to recover after the insult in the second group. But in the short group where we didn't allow recovery, the chondrocytes looked like condylolysis with decreased uptake, staining, and cell viability. But this was just a mini pain pump that we plugged into the glenohumeral joint of a rabbit, sort of to say, hey, is this the real thing? And then there were a number of other studies by Connie Chu and others that said, what about single-shot dosing and so forth? And I think ropivacaine right now seems to be the least toxic, but many have still not changed their clinical practice for post-operative injections of lidocaine and things like that. And it seems that in culture it might be problematic, but does not seem to be much in the way of evidence that using a single-shot injection in the operating room where there's not prolonged exposure, there just doesn't seem to be an issue. I think the other way to maybe think about it is in the knee, there were just as many pain pumps used in the knee, but we rarely saw condylolysis in the knee. We have case reports and so forth, but post-op, there's a hematoma, it's much larger volume, the stuff probably doesn't stay around. But if you put it in a joint, where in the shoulder joint where it has nowhere to go, it's just constantly bathing the cartilage. So I suspect that it has something to do with it. In addition, I've hardly ever seen pain pump condylolysis in the shoulder in a rotator cuff repair. So that's probably an open system, things are oozing out and so forth. It just seems to be these labral repairs, things like that, where we're identifying these patients. So just food for thought from clinical practice. So these patients that they come in are actually clinically very challenging. They remember, we're kind of in the business of reducing pain and associated function, and they want something that's meaningful. And the challenge is that they behave a lot differently than the older patient with osteoarthritis. They come in and they don't have this smoldering, increasing pain over time, but they have horrible, horrific pain that's developed over a short period of time. And it's almost like it's neurogenic. So it creates certain treatment challenges. So you ask yourself, why wouldn't you just take these patients, just like the knee discussion, why wouldn't you just do a total shoulder replacement? And the main reason is that the glenoid component has a shorter-lived timeline that probably will fail in many, but not all, over a 10-year period. And the people that we were treating were sometimes in their teens and 20s. So we were searching for options. And just like the knee, we came up with these sort of what I would say are intuitively driven treatment algorithms, but certainly not based on any evidence. But we said, well, can we take the same decision-making we use in the knee and apply it to the shoulder? And the algorithm is pretty similar. So the first thing that I do is when they come in with any etiology is debridement capsule release. And if they don't have a biconcave glenoid, the glenoid is actually structurally flat, this is even for osteoarthritic patients, you can get a pretty decent result with a full capsule release. Sometimes we'll even do an X-ray nerve dissection. I don't care so much about humeral bone spurs. We do a posterior, anterior, inferior capsule release circumferentially. And the results have been pretty good for about 2 to 3 years, but a certain percentage of those will reappear and stiffen again and still have pain. So it's a transient measure, but the other thing it allows you to do is get index information if they can be a transplant candidate for something in the future. We do use marrow stimulation. We now have 2 series, one with longer-term follow-up. And again, if they have relatively localized disease, these patients are typically those who have anchor arthropathy. In other words, largely the shoulder is intact, but maybe an anchor has been proud or dislodged, and they get localized or geographic damage. These ones have actually responded reasonably well to marrow stimulation, and we even use biocartilage arthroscopic. We have some cute cases we show how to do it technically and so forth. And in general, if the damage is relatively limited, you can get some time in these groups by localized treatment. We've tried basically everything. We have a couple of patients where we used ACI in the humerus, and it was very tedious. The humeral head cartilage is extremely thin, so these are when you usually call the fellow in to start sewing because you need a lot of patience to get a P1 cutting needle through the articular surface. But amazingly, this is a kid who was a baseball player. You wouldn't know it by his habitus, but he was actually a pretty good athlete at one point and had to shut down because he had so much pain. And he ended up having a focal defect and ended up getting back. This is another little girl who's a gymnast, and she had a humeral head defect. We don't know the cause, and ended up getting back as well to pretty high-level activities. And she's still good. She's over 10 years out now after ACI. But obviously, there's other options that we move along with that are easier. I'd say now my go-to, especially because many of these patients have subcondylar changes, they often come in with cystic changes. That top left image, the arthroscopic image, is a patient with ankle arthropathy. So that's after having a proud ankle where the joint, the humeral side had a geographic lesion, but the glenoid side was intact. So that's a perfect patient, in my experience, to have just an isolated osteochondral allograft. And all the same principles apply. We use a proximal humerus, although Matt Provencher's been talking about using the talus because the radius of curvature matches, but we can generally get a proximal humerus in a reasonable amount of time, and the treatment is exactly the same as we use in the knee. Everything really similar in terms of post-op protocol, graft preparation, and so forth. And the results here, we have 3 series now. One we're going to publish long-term results, but essentially if you use a fresh graft, not a frozen graft, you keep your indications pretty clear with localized damage, the results, first from a radiographic point of view, they all seem to integrate. But the issue of pain, if they're not a chondrolytic shoulder, but rather a localized damaged shoulder, they can actually do quite well. We did dabble in big grafts, and I'll show you some examples of that, where we take the whole humeral head, but those are really salvage situations. So the real challenge is when the glenoid is involved. So if we're lucky enough to have humeral disease, we can do a lot of different things that are somewhat predictable, but what the bigger challenge is if they have significant glenoid disease contributing to their pain. One of the things we know about arthroplasty is that virtually every study in the literature that we've compared hemiarthroplasty to total arthroplasty, and those who have bipolar disease shows that total arthroplasty does better clinically. So the glenoid is incredibly important to manage if it's involved, because just looking at the humerus because it's easier to manage and ignoring the glenoid is probably not going to do it for us for the worst patients. So what are the indications in patients that we can treat bipolar disease? If you're lucky enough to have relatively focal disease on the glenoid, you can do a lot of the same things there that you can on the humeral side. But if they have disease like you see on the right, these are patients, the bottom right is rotator cuff arthropathy. The top is standard posterior wear for glenohumeral arthritis. These are not the patients that I'm treating. Ruben Gobisi now has a pretty decent experience of using the tibial plateau. We did some radius of curvature matching showing that you can use the medial tibial plateau from a cadaveric donor, from a living donor, if you will, and it will match the radius of curvature of the glenoid. And you can actually put this in arthroscopically. It's challenging, but allografts of the glenoid are relatively new. We do use allografts in the inferior glenoid rim for bone loss. We use distal tibia, not uncommonly for major areas of bone loss. But the central glenoid, like you see here, one option is the medial tibial plateau. Another option is just to treat them like Rick Madsen has taught us with a ream and run. In other words, do what you want to do on the humeral side and then do a ream and run to create fibrocartilage, something that's concentric that matches the humeral side. And in the middle-aged to older degenerative patient who you don't want to put a glenoid in, this is actually a reasonable option. We looked at all of these different types of interposition grafts. They've been interesting. For a couple of years, we were fixated on using the meniscus. In a biomechanical study, time equals 0, we showed that if you take a meniscus, you can offload the glenohumeral joint, and it seemed to be, at least intuitively, a good idea. And then we, like many things, long-term follow-up shows you how badly you're doing, and we took these patients who had meniscal allografts and then followed them out for longer periods of time, and the failure rate was in excess of 70%. So it just didn't work very well, but it looked good, and it was fun to put in, but it just didn't heal well, and it created a big scar ball, so we don't do it anymore. What's really interesting is there's sort of 2 spectrums of publications that show you can get amazing results with some type of soft tissue interposition with bipolar disease when the glenoid is involved. And so Krishnan's series had 86% good and excellent results, and J.P. Warner's had a 92% failure rate. So I don't think it has anything to do with the surgeon ability. It's just we're not always comparing apples to apples. If you're looking at a series of these patients and they are truly chondrolytic patients, virtually nothing works other than replacement or some of these types of salvage where you do bulk allografts. If they're arthritic patients with early disease, those patients might actually do well with soft tissue interposition. So they're really 2 different animals. We published this last year in shoulder and elbow, and we were trying to say, let's borrow again from the knee, and we started doing basically an AMIC procedure on the glenoid, where we drill the glenoid to take a collagen 1-3 membrane, and histologically our results from this looked actually pretty impressive, where we could control the marrow stimulation response with fibrocartilage fill by putting a collagen membrane over the area. So that's it. Now what I typically do, we'll do sort of a ream and run and put a dermal patch or a collagen membrane over the glenoid and hope that they get good fibrocartilage fill. This is sort of the highest level of what you can do, and this is a guy who had condylolysis. He's a wrestler from the University of Iowa, And this is clearly salvage. We took off his entire humeral head, created a mushroom-type implant, lots of subchondral bone there, so that's a worry. We used a meniscus, and he still has his graft in place. So who would know? It's just one of those things that you're trying to do this. You burn no bridges by doing this, but you have to have sort of modest expectations if this whole construct's going to survive, and in fact, it did for him. So just a couple sides on the elbow. The elbow is an easier place to manage because the most common condition that we deal with is a singular condition of OCD, the capitellum, at least in my practice. I haven't extended this to anywhere else in the elbow. And this typically occurs in adolescence. When they're younger, that would be Panner's disease. So if you get a skeleton immature with what you think is OCD, treat that non-surgically because that usually resolves. That's a different condition. So this is full-fledged OCD of the capitellum, which is a lot like the knee. And it's possible the two patient populations we see them are in those who are exposed to repetitive valgus, typically baseball, and then or axial compression, so that's typically gymnastics. And they present, as you might expect, with lateral elbow pain, motion loss, and mechanical symptoms if they have a loose piece. And the treatment is non-operative if it's a stable lesion by MRI and they have some just lateral elbow pain. We'll shut them down for 4 to 6 months. We don't cast them. We just try to get them to heal. And the younger they are with the less cystic change, just like the knee, the more likely they are to heal. However, if they're unstable on MRI and they have mechanical symptoms, it's really too late, I think, for rest to have any benefit, and they need surgery. So this is really what's most commonly done. You get in there and there's a loose piece and you're saying, well, maybe I could fix it. I have yet to find one that I felt comfortable fixing. They almost always are pure cartilage with a tiny piece of bone, and you're sitting there scratching your head saying, should I put a screw in it? Should I open it up? And I almost always take it out. And as long as it's not uncontained in the periphery of the capitellum and it's somewhat central, they do well. They do extremely well. And virtually every one of our athletes, when we remove it with or without marrow stimulation, after you remove it, and it's all done basically arthroscopically, they do extremely well. But there are some those that don't do well, and this is the challenge here is decision making. So to restore the surface, you can fix it. Never done it. Just haven't seen the lesion that I felt like I need that it would work, or that I wanted to go through the trouble because the removal does so well. But if you have to go back in because you have to revise it, you could use an autograft or an allograft. And we've looked at donor sites, and from an autograft point of view, there's several places you can go in the knee as a donor site. And we looked at 4 different spots, and all 4 of them, when we mapped it by CT scan, were able to map out against the capitellum. I don't like to go to the knee for graft, so I'll just use a donor femur, and not a capitellum, but a donor femur now, because I have just as much confidence in allograft for cell viability as I do autograft. So I don't use autografts anymore, and I use allografts, and we take it from the knee, and it works very well because these are fairly small lesions that don't have any distinct differences for anatomy. Osteochondral autografts this is a recent systematic review, looked at 7 level 4 series, so a fairly good-sized group of patients. And I'll just take the take-home of using a restorative technique in the knee is a lot like the decision-making in the shoulder, a restorative technique in the elbow is a lot like the decision-making in the knee and the shoulder. The problem with these series of patients is that many of them were getting primary treatment because it was interesting to the surgeon to just do an autograft, when in fact, as I told you, the vast majority do great if you remove the piece. So obviously, intuitively you would say it's great to have someone home and fill the defect, but the reality is once you remove that piece, they behave a lot like OCD in the knee. It's a contained lesion that is shielded, and the radial head doesn't edge load it sufficiently. It just works on the periphery. So long-term arthritis is not a problem that we see repeatedly when we're dealing with capitellar OCD. It seems to be a relatively shielded area. The patients that I would indicate for this procedure would be those who you do that and then they continue to have pain or they have recurrent pain. I think this is an excellent salvage option, as well as allografts, which is pretty much my go-to now for a failed OCD, the capitellum. And amazingly, you can even do these arthroscopically if they're very far posterior. So final thoughts. Young patients, when it comes to glenohumeral problems, are very different than older patients with osteoarthritis. They have much more pain. They often have neurogenic type symptoms. They're just more difficult to manage because of that. Not all cartilage destruction in the shoulder is chondrolysis or due to a pain pump. We're still struggling with the best management on the glenoid side. And OCD, the elbow is pretty easy. If you see it and treat it, the most common thing you'll do is remove the piece. You can decide to do marrow stimulation or not. There isn't a study, to my knowledge, that says that marrow stimulation makes any difference. We end up, most times, just cleaning up the area, making it bleed a little bit, but we return them back to sport on a timeline that's different than what I would typically allow for marrow stimulation. We let them go back when they feel well, and that could be as soon as 6 weeks in a gymnast. So little bit different treatment algorithm in that regard. So again, thank you. And if any of you guys have further interest in some of these topics and a bunch of others in sports medicine, you ought to consider this course. We preserve 4 days during the day is all preserved for skiing. So early morning, late nights, but you get a chance to recreate at the same time. So love to see you there. Thank you very much. And thanks, Tom and Andreas. So I think Lisa, I think you're going to be next. Okay. And do you have your talk on the system? Okay. But while we're switching over, any questions? The question is, why am I anti going to the knee for autograft? I think that, because all it takes is one patient who says I have knee pain that didn't have it before. And especially because I'm pretty equipoised on the value of an allograft versus an autograft. In other words, I'm good with using allograft tissue in terms of small grafts like this. We have one patient, I work with one of my hand partners, he had a metacarpal head defect, went to the guy's knee, took a 5 millimeter cylinder of bone, and he's got chronic knee pain. He's worked comp too, but for whatever that's worth. But it's just more reason to say I hurt. So it's mainly just because to say it's zero morbidity, anytime you touch someone with a knife, there's a potential for morbidity. So now he's got chronic anterolateral knee pain and his hand is fine. So that's obviously it's anecdotal, but I have enough confidence in an allograft that I would rather just not rob the knee. That's the main reason. Okay. All right. Thank you very much.
Tom was just muttering, I have a bad elbow and a bad shoulder. and I think all of us, when Wayne was talking yesterday, are like, ooh, I'm going to go buy some Hoka shoes. So I think at least for most of us that are getting up there in age, we're looking at all this like, what am I going to need next? So I do have to leave for the airport after this. I just want to say again, thank you for having me. It was really lovely, and I learned a lot from my colleagues as well. I'm taking Jimmy Cook's place. Jimmy Cook is a small animal orthopedic, a dog orthopedic surgeon, and does much of the same work that I do in large animals at Mizzou. And I think we were charged really with how do we think differently about animal models to study musculoskeletal disease. So I hope I can convince you that we really need to completely change the paradigm on how we study any drugs. I'm going to present a study on how we studied stem cells for osteoarthritis, because I firmly believe that the current models, remember the old dog model used to be called the Panuki, when they would cut the anterior cruciate ligament, and that's not allowed. Rarely will you read a study anymore because it was such a rapidly advancing OA that pretty much everybody said that's too cruel to the animals and it's too rapidly advancing, so you can't really study anything. And yet when you read all these mouse and rabbit studies, they do the same thing. They cut the cruciate and sometimes they destabilize the meniscus. So all these things are just too messy to really study arthritis. And I think Tom touched on this in the very first day, that when you have arthritis already there, you're not going to really be able to study things that work because you're studying it too far down the cycle. So I think every researcher would agree that what we really need to study for arthritis is very early post-traumatic arthritis, to deconvolve the system, simplify the system, and then we can figure out what works early in the disease process to apply it later on. So hopefully I can convince you that we have a better way to look at this disease process. Andreas gave you a nice review about stem cells. What are they? Lots of different types of stem cells. The old paradigm used to be that if you had a bone marrow-derived stem cell, you wanted to push it down mesoderm, ectodermal, endodermal lineage. Maybe you wanted to turn it into muscle or into cartilage. We don't think that happens anymore. So when you read studies that say, well, we tracked the stem cells and they didn't turn into cartilage, it doesn't matter. That's not how they work. Then people robbed from this paradigm on the right-hand side of the slide, where macrophages are known to polarize down to an M1 or an M2. That's really an oversimplification, but macrophages, I talked about the other day, are really chameleons. So macrophages, monocytes are known in the immune system to go down an M1 or an M2 pathway, and they're either reparative or pro-inflammatory. So then people thought, well, that's what stem cells are doing, and that's not true. That was published there's only like 2 publications, but it really became accepted paradigm. But one of my PhD students and others have proved that that doesn't happen either. So the contemporary thoughts is that these cells really act as immunomodulators and modulators of the local environment. So we know a lot about what the cells deliver, how the cells respond to the environment that they're put into. So if you put a stem cell into a kind of a quiescent joint, that's completely different than if you put it into a joint that has inflammation in it as well. So lots of people are studying these sorts of things. So the current thing is that it's all about these extracellular vesicles, these endosomes, exosomes, all kinds of these little vesicles. And lots of people are looking at ways to capture these vesicles and deliver them. Maybe they're implanted in gels or little cages so that it can be more like a drug. So you can deliver these active vesicles rather than implant the cells and hope that they respond to the environment. So that's really the way that we think they work. So if you have these little paracrine vesicles, they act on the environment, they recruit stem cells, they modulate the environment, they recruit more stem cells, and those local stem cells in your body, and they are everywhere. They're in your teeth, they're in your skin, they're in your cartilage. Then those stem cells secrete more vesicles. So that's how we think stem cells really work. So we've been looking at stem cells in the wrong way, and then we've been using the wrong animal model to look to see if they, or other drugs, if they actually work. The other thing, as I said, stem cells in the middle live in this kind of quiescent state. They are anti-apoptotic and they can do some things, but they really need to be activated. And the term that you'll hear now is called licensing. So we know that they have to be, and it can be anything from dead cells to inflammation, but they really need to be activated to then effectuate their response. So you can't rely on the body to always be in the right status to activate it. So that's again why people are looking at trying to take stem cells, activate them in culture, capture these vesicles, and use the vesicles then to have their effect. So what I wanted to tell you about is we tried to use these stem cells. This is, Lars, you might know of this company. This is Zentella from Lund, Sweden. Came to us and asked us if we could look at this fancy stem cell that they had devised, and they said, we want you to put this in your cartilage repair model. So we would make a defect, a full thickness defect, usually on the lateral trochlear ridge of the femur, and implant different goos, whether it's biocartilage or stem cells or whatever it is. And I said, no. We want to look at this in early post-traumatic arthritis using this model that was developed by my graduate student, Michelle Delco. So these are selected stem cells specifically for this alpha-10 beta-1 integrin. And this was a FDA study because they want to get compliance. So tons of paperwork and but also what this confines us to, and it's an FDA study, is we have to use known outcome measures. And known outcome measures is staying with the norm, but we can make some other fun observations. So again, using all the ways that we know are already published and pre-established, we kind of find no differences. But when you look in a more creative way, and I don't want to take credit for that, it's my graduate students that do this, we can find different ways and discover different ways that stem cells work. So this is the alpha-10 beta-1 integrin is a cell surface. This is a chondrocyte right here, the bilipid membrane, and it is known to bind to the extracellular matrix. It's known to be important for mechanotransduction, all kinds of things. So they chose this cell based on the group at Zentella really did this work. And we know that there's another myth that stem cells are immunoprotective, and that's absolutely not true. You should be very careful to use allogeneic stem cells. So they chose this because it does form a lot of good cartilage, as you can see by the collagen type 2 compared to those that are alpha-10 beta-1 negative. They showed that it has all the right markers to be a stem cell. And they know that it's negative for this MHC class 2 molecule, which we think is the most important one for creating an immune response when you use allogeneic cells. So we developed this model of early post-traumatic arthritis in the ankle because in the horse, just like in the human, you don't get ankle arthritis unless you have trauma. You don't get ankle arthritis because you're fat or you race too much or any of those things. There is some known trauma at some point to get ankle OA. because this is such a cool model, we actually recently just were rewarded a 5-year R01 to use this to study a different peptide that binds to the mitochondria. So Brian already said about difference in cartilage in all the different joints, and Karen Novakovsky, who is now in medical school, did this great study showing how all the different joints in the horse, just like in the human, respond differently to mechanical insult. They respond differently to biochemical insult. And so we chose the talus again because we want to simplify the system, study trauma, study early arthritis, and see if we can find changes. So this is where the ankle joint is. It's called the hock in horses and dogs. So if I slip up and say hock, I'm really talking about your ankle. And using this model too, then we can say, is any of this stuff complete BS that we tell our patients to do? We really have no idea after a bad ankle sprain. Even a moderate ankle sprain is really what we're creating. We have no idea what to tell our patients. I don't know to tell my patients, you don't either. Does it matter if you're non-weight bearing? You tell them all this rice business, but my philosophy for everything is get out and go exercise. So I don't know if any of this is important, but using this animal model, then we can test those things because we can control our exercise in horses, unlike you can do with rabbits and mice and rats. This is a great picture I like to show because it shows the difference in the animal size. These are all the talus of different species, including the human. And you can see that little speck on the bottom is the rat. So imagine how small. We couldn't even get a picture of a mouse on there because it's so small. And there's Farsh Gilak has some really nice work using post-traumatic arthritis in the ankle of rats, but it's a shit show. Like there's a distal tibial fracture and all kinds of things going on in there. And can you discover good things? Yes, but I think this model is much more elegant and it will be able to make much better discoveries that are clinically relevant to our patients that have mild to moderate ankle sprains. So this is just a picture. So this is a cadaver specimen, and this is our impactor. And the impactor goes in arthroscopically, and we make impacts on the medial talus. This is a horse, so the horse would be in dorsal recumbency. Here's the joint that we are operating here. And so here's the arthroscope coming in. We call this the distal intermediate ridge of the tibia. Here's the intertrochlear groove. And you can see we've made 3 impacts on the medial talus. The difference about this impactor, lots of people, Mark Hertig and others have similar sorts of impactors, but the difference is our crazy engineers outfitted this with a very high-speed LVDT camera so we can measure rate. So how these work is you basically cock it back and bang, you hit the cartilage. And so you can say, I delivered 50 megapascals, but that hitting, how hard you hit it, isn't as important as how fast you hit it. So using this impactor, we can say, I gave you 36 megapascals per second. We can measure strain rate that was delivered to cartilage, and that's what's important for injury, and we've shown that. Lots of people have shown that, and nobody else has that ability, and it's arthroscopic. So all we have is a simple arthroscopic hole, make a simple impact, there's no fracture, and so being able to measure rate, then we can say, I gave the same impact to these 10 horses or 10 joints, so we can really control for a lot of background noise. So I can't even remember why I have Aldo Beckham up there. That's just to say we don't want to create the fracture and all those other bad things. We're really trying to say, what do we do to our patients that have mild to moderate sprains, strains? So we did early studies in horses, and we looked at them at 6 weeks, 12 weeks, 8 weeks. We didn't look at earlier than 6 weeks. And we know that by controlling the strain rate, that we can either create a mild articular cartilage damage. You wouldn't even see this on a scope. It's just an indentation in cartilage, but you can see the loss of cells and proteoglycan here. These are probably chondroprogenitor cells that are trying to effectuate repair. You can see advancement of the subchondral bone right here. See how the bone is coming up? And for sure we see sclerosis by 6 weeks as well. We can give you partial thickness cartilage loss, so you can see more loss of proteoglycan, just a partial thickness, again, activation of the subchondral plate really early. Or we can create full thickness cartilage loss. So we can really control and then study what this looks like. So these are the arthroscopic pictures of a mild to moderate, and then we can certainly hit it really hard. And then the physicists at Cornell kindly made me an intraoperative microscope. So this is, again, a 4-millimeter scope. This is a confocal microscope that I can put into the joint and look at cells live. So here it is in the joint looking at one of our impact sites. The cells autofluoresce, and I still don't know what this is. We've done proteomics, lots of things in your cells fluoresce, like flavins and other things. I still don't know what these are. We did Kira Novakovsky, not me, went in and cut all these little cells out and did a proteomic study. So now I have 10,000 candidates to look at what these autofluorescing things might be, but these cells are on their way to death. I just don't know what that pathway is yet. This is the extracellular matrix that you can look at, and then you can put fluorescein, just like you use to stain your eye. You can put that into your arthroscopic fluid, and you can see when cells are alive or dead using this intraoperative scope. So we can, fortunately at Cornell, our IACUC allows us to rescope them up to 4 times. So we did a few horses, impacted the talus, and then at day 4, post-operatively, we injected them with 10 million of these alpha-10 beta-1 stem cells. Why 10 million? I don't know. That's what people use in horses, 10 to 20 million, so that's what we did. We rechecked them at 3 months and scored them by ICRS cartilage repair score, and then euthanized them at 6 months. I asked the company if they really want to track their cells, the easiest way not to mess with the cells is if they give me male cells and I put them into female horses, and they gave me female cells. And it was too late, like the horses were lined up and we were ready to go. So they want to do another study after this to add more numbers to the study that I show you, which is really a proof of concept. But so I don't have any evidence of cell tracking in these. We have a quantitative way to look at pain now, but it didn't at the time. We have a gait analysis lameness locator. Convention for us as equine practitioners is to use this subjective scoring system on a 0 to 5. No horse was ever lame. We took radiographs at multiple time periods. You can see how many times I tapped their joints to look at the synovial fluid. We measured all kinds of things. Dick Heinegard's helping us look at comp, all kinds of fun things. We measured all these things by ELISAs. So we worked really hard to try and figure out, we want to know, are we getting arthritis? Are we changing the development of arthritis? And do the stem cells work? So PGE2 is well-known modulator secreted by stem cells, and then many of the others are markers of arthritis. I already said we did the ICRS. After we euthanize the animals, the limbs get on the bus, and there's a campus-to-campus bus that leaves Cornell campus in Ithaca and goes down to New York City multiple times a day. So we commonly ship our limbs down to Hollis Potter at HSS, and she does MRI in her group, and then they ship them back up to us for histology. So even based on our radiographs, so this is probably the same as you can see that there's soft tissue swelling here at 6 weeks. But even based on our radiographs blinded, so Michelle Delco, the graduate student, and I scored them all together, consensus scored at the end of the study. And even based on the radiographs, the treated side had less subchondral bone sclerosis. They had more joint swelling too. The ICRS scores, so this is again, it's not really designed for early post-traumatic arthritis. It's more of a cartilage repair type of scoring system. And we didn't see any difference. They were both control and treated were worse than the time 0. So we are creating arthritis in both sides, but we didn't see a visual difference between the treated and control side. PGE2, as I just said to you, is a marker for stem cell secretion. For all these following slides, the solid black line is the stem cell treated, and the dotted line is control. So you can see there's more PGE2 at multiple time points in the treated side compared to control, and it stays above it. Collagen type 2 homeostasis is really important, right? You want to know that you're creating new type 2 collagen and you're not losing more collagen. So it's not just that you want more of repair tissue. You don't want just more GAG and more collagen. You want to know that what is being created is staying there. So this marker, this CP2, is a marker of new collagen synthesis, and then this one over here, C2C, is a marker for cleaved collagen. So what's really cool is you see that we are producing, again, the black line, we're getting more new collagen, and we're stabilizing, and we're getting less cleaved collagen in the treated side. So we're stabilizing the joint. And this is the coolest finding that I still don't know what this effect is. So when we put them down, we open them up, and this is a medial trochlear ridge of the talus, lateral trochlear ridge, distal mediate ridge of the tibia. So we would look at them and score them, and then we would apply India ink, which just is particulated carbon that will stick to areas of fibrillation. We'd look at the opposite side of the, we call it distal, I think you guys call it inferior tibia, to make sure are we getting whole joint osteoarthritis. And so maybe if you kind of defocus your eyes, you can see on the left here how kind of dull this one looks and how shiny this one looks. And you could say, well, that one got air dried, or maybe you wiped it off or something like that. But when we put particulated carbon over here on some of these, we can't find the impact sites. And at first I thought, I had this technician who was losing his mind when Trump was about to be elected. Like, he just could not function. He was so afraid of what was going to happen to America. And I was like, how can you get particulated carbon wrong? Like, it's in a bottle labeled India ink. So I was like, ugh. And I went up to the lab and got it myself, and he had the right stuff. But for some reason, the treated side, the India ink never sticks. Is that hyaluronan? Is that lubricin? Or is this cartilage intact? Because particulated carbon doesn't stick, but it's also much shinier. We didn't score it for this, right? That's not something you normally look at when you score a histology slide, but it was just this weird observation because the India ink didn't stick, and we impacted every joint. So I still don't know what that is. And then one of the things, remember, we talked about stem cells recruit other cells. So in the treated side in these horses, we have more cells in the synovial membrane histology. So myself, Michelle Delco, and a board-certified pathologist all consensus scored these as well. When we score them, we're just looking for cells. They're not neutrophils that are in there. They're mononuclear cells, but we don't know what they are. Are they stem cells? Are they, remember I told you there's that M1, M2 macrophage? Are they the M2, the reparative macrophages? I don't know. So we're currently doing RNA studies and immunohistochemistry to find out what are these cells. Maybe they're stem cells, I don't know, or they're happier cells, but for sure we see more cells in the treated side. And the coolest thing, really, one of the cool things is the histology. So there's multiple things we learned from this histology. We have the standard ORSI scoring system. For sure there's less fibrillation in the control in the treated side than in the impact. So on all these slides, control will be on the left, and then here's impact. So these are two different horses, H&E and saffron and no fast green. So you can see here's control, which are normal in all of our horses, then impact, control, impact, treated. So look at how, for sure, we impacted it, right? You can see the slight cartilage fibrillation, chondrocyte death, but compared to the impacted site where there's breaking of the subchondral bone, and remember, I know that these horses had the same strain rate. They had the same injury applied to them. There's no difference between these horses. But it's universal, like here's impact, control and treated, control and treated. So we saw less cartilage fibrillation, less subchondral bone sclerosis, less advancement of the tide mark. What came first, the sclerosis or the impact or the articular cartilage? I would contend that I think somehow these stem cells are stopping the cartilage degradation, keeping the cartilage surface intact, and then you don't get as much subchondral bone sclerosis. These horses are, after their stitches come out at 10 days, they're free to exercise. This is not a controlled exercise. They're turned out to paddock. So lots and lots of cool things, and you can see in the treated side as well, see how there's massive chondrocyte clustering down here? Those are all like stem cells trying to get out of their native matrix and really repair the tissue. We didn't see that in every case, but certainly more in the treated side than in the control side. So that was significant as well. So this is really fun. None of the standard scoring systems show that stem cells work. Again, I think it's fascinating that some of them didn't stain for India ink. We are measuring lubricin. We're shipping samples over to Sweden to get comp measured as well. We don't know what these cells are in the synovial membrane and how is it protected. We did 3T MRI. There's no difference. The cartilage in this joint, like in the human ankle, is less than 1 millimeter thick. So it's really hard for even somebody as wonderful as Hollis to stratify that articular cartilage. So there's no difference in T2 mapping. And then it was really hard to do T1 row on such thin cartilage and such a curved surface as well. And we didn't have the brains to think, well, we should do CT on these. But now when we go forward, we're going to be doing multiple CT exams to look for because then it doesn't have to be invasive either. We do have to anesthetize them. But then we can really follow the progression of subchondral bone sclerosis as well. And now using this model as well, this is another graduate student who really discovered that with Hazel Zetto, who's a MD pharmacologist at Cornell Weill, Hazel has a company called Stealth Pharmaceuticals, and what they're doing is taking this compound called SS31, and what SS31 does is it binds to this protein called cardiolipin. This is going to sound like I know more about mitochondria than I do, but remember that horrible respiratory chain that we all had to learn about, and then you get oxidative phosphorylation, and that you need that to be a healthy cell. So your normal mitochondria is this really wavy structure, and when it's unhealthy, it kind of unwinds. And the protein that is important to keep all those elements of your electron transport chain together is this cardiolipin. But if it dissociates from the inner mitochondrial membrane, then your mitochondria start to unwind. It doesn't mean you're dead, it just means you're unhealthy. You're aging, you're traumatized, something like that. You give this SS31, which is chemically small enough and not charged, so it actually penetrates through articular cartilage very quickly. We've shown that with labeling confocal. And it's very specifically and only binds to cardiolipin, which is on the inner mitochondrial membrane. So when you think about chondrocyte drugs, it's not just important that it can penetrate cartilage, it needs to stay there. So that's really cool that it has to penetrate the outer bilipid membrane of a cell, and then the inner mitochondrial membrane as well, and then it specifically binds in there, and it does that very rapidly. And then it restores mitochondrial health. So Michelle Delco has several publications now on this, and that's what we'll be studying in this post-traumatic arthritis model as well. That's it.
Thank you for your talk. I'm really interested in your alpha-10 beta-1 MSC study. First question is, what was the rationale behind selecting that particular integrin? Is it because it's involved in mediating chondrocyte adhesion? And then secondly, based on your really good results from your staining of the pellet cultures, where would you like to go further with the study? I could have missed it if you had talked about it.
Why did Zentella really choose the alpha-10 beta-1 integrin? And then based on the staining of the pellet culture, where is it going to go from there? The pellet culture stuff is interesting if you believe that stem cells turn into chondrocytes. But it shows it has more chondrogenic potential. The alpha-10 beta-1 they chose because they were hoping that would help the stem cells stick to the cell surface. And maybe they do, but I couldn't track them in this study. There's a lot of thought that if you have a early cartilage damage and you have a slight fibrillation, that's where you want the cell to stick. I didn't even go to the bar last night, and I can't say that. So maybe, but I don't know that from this study. I should do that ex vivo. That's a good idea. I could bash the cartilage and then put the stem cells on there with a fluorescent tracker and see if they actually stick to the cartilage. Yay, more work.
Thank you.
Brian?
What's the difference, do you think, in this model versus your more traditional model? You alluded to what you used to do by the ACL. So you let it develop over time and come back. It may have more diffuse change. It's much more inflammatory, I assume. So do you think that's still too hostile an environment for these cells in this setting where there maybe isn't as much of an inflammatory process going on?
Brian's question is really about animal model. Is there any place for cruciate ligament, medial meniscus? I think those are going to be very difficult because you have an ongoing biomechanical instability. So I think what I don't know with this, we treated them on day 4, right? What if I let them go to 3 months? So those are studies that certainly need to be done, but I think this is the type of study that needs to be done as a proof of concept. Yes, this can work. I just think it is too hostile of an environment when you have a torn cruciate and a destabilized meniscus or an intra-articular fracture. Those diseases advance so quickly, it's really hard to see any difference.
But what about the degree of sort of inflammation in the joint that we have much more catastrophic problem in the joint? Forget about valve mechanical part. Is that too hostile environment to get the same benefits that we might get there?
Then the follow-up question is about inflammation. I think arthroscopy creates a fair bit of inflammation, right? Like you follow those cell counts, they're pretty inflamed for up to 4 to 6 weeks, just with a simple scope. You don't even have to debride anything. So I think this is an inflammatory environment, which I think is good because that activates the stem cells, which is another study you could do, right? You could take normal synovial fluid and synovial fluid from like day 4 in these horses and then see what it is that really needs to activate those cells. So I think it's good to put them into an inflammatory environment. You going to go find them now, Lars? It's close to being approved by your regulatory body for human use.
All right. Good morning. I'm Chris Kyoto from the Brigham, in charge of foot and ankle. I'm going to give you an overview today, more clinically, of options available for talar osteochondral lesions. I want to thank Andreas before he steps out, and Tom. Tom, as a resident, told me with regard to cartilage lesions in the knee, and it applies to the ankle, don't forget stability, don't forget alignment. I see a lot of presentations where osteochondral lesions are scoped and the joint's wide open and no one's done a brostrum. And Lars will come to that in a second. Also, talar cartilage is different and has an interesting approach to department meetings. I agree with sometimes. Andreas, thank you for always asking me, how does this really work? I think of him as a Kirk Minahan of cartilage and really challenging our thoughts, at least in the locker room and the coffee or the water cooler. So, unbiased, foot and ankle is special. I hate to do this to you, but these are all active patients we've been seeing over the last few months or so, including necrotizing fasciitis, and a guy on the left is about half a mile away from me. He's going to lose his foot this morning, and deformity and fractures. But seriously, the ankle and the talus is special. The ankle has a lot less surface area than the knee or the hip. It has increased forces. It's closer to the ground, so you have your ground reaction forces, and it has a greater potential for degenerative cartilage and wear due to increased stress. And yet it's thin, so you've got all these increased forces and decreased surface area, and yet it's thinner. And the incidence of idiopathic ankle OA is relatively low, and that idiopathic ankle OA might actually be occult instability. So majority of arthritis is post-traumatic, and focal condyle injuries are more common than ankle arthritis. This slide applies to our treatment approach when you're considering allografts for the ankle. The ankle is very congruent and constrained, and it's difficult to get to sometimes, at least when you're trying to come in at a right angle to put in an osteochondral plug or graft. So it really can be a challenging environment. So it is special, and it's challenging and very intriguing. Moving on to today's topic, talar osteochondral lesions. They're relatively uncommon, 4% of osteochondral lesions. There may be a genetic component based on bilaterality. The etiology is unclear or varies or is multifactorial, and folks have talked about trauma, ischemia, embolic events as potential contributing factors. The lateral lesions are usually traumatic, whereas the medial lesions are not. There are numerous staging systems. I won't take up too much time here. This is an MRI staging system. And I think the 100,000-foot view is to understand that you have to look at these lesions as, is this an injury or a problem of the cartilage, or is it an injury and problem of the cartilage and bone as well? In terms of treating osteochondral lesions, these are your options, and non-operative treatment is on there. It's not necessarily as effective as some of the other modalities, but we should mention it. You have microfracture, which we'll see as our workhorse, osteochondral grafts, either mosaic plasty or bulk grafts. We'll talk a bit about pediatric cartilage and then wrap up with some discussion on ACI and MACI. So what about non-operative care? Yes, try it. It does work in probably about 40 to 50% of patients. I treat patients with a boot and partial weight bearing with crutches. I'm trying to avoid that combination of load and shear to protect that vulnerable cartilage. I think that some motion is fine, but if you have load and shear, that's a bad combination. Afterwards, get them involved with physical therapy for instability. I think that's really important. There is some limited evidence for biologics, and I won't discuss that. This is a meta-analysis or a systematic review looking at non-operative treatment. It's 45% successful. The folks who were arrested and still allowed to move did better than the folks with cast immobilization. Here's a slide on the natural history of talar osteochondral lesions. And these were patients who were minimally symptomatic, and they followed them, and 86% of patients were still pain-free or less painful and did not progress on MRI. So the presence of an osteochondral lesion doesn't necessarily mean that you need to operate. And here's just some earlier studies on perhaps PRP or HA in the non-operative treatment of osteochondral lesions with some limited success. My final answer, boot and crutches, have your patients stop smoking. We have an article out of our group that's going to hopefully be published in Foot and Ankle in the next few months looking at vitamin D levels, and the incidence of hypovitamin D was 54% in the osteochondral group versus 28% in a comparative cohort with sprains, and again, PT for instability. But still, we operate. Tom, this is a slide where we'll come in laterally, and we'll address the osteochondral lesion, but also a calcaneal slide there, and we'll do an osteotomy as well. We'll either do a calcaneal osteotomy or a first metatarsal osteotomy. This was a modified Brostrom. Last night at dinner, I was talking to Dr. Peterson, and he told me that Carlson was his medical student. And so perhaps instead of saying the Brostrom modification, we should call it the Carlson modification, the Peterson modification of the Brostrom technique. So here we've gotten smaller incisions, and just to point out, Tom, to your credit, there's an osteotomy of the first metatarsal addressing both alignment in addition to the instability. We pull in a tight cuff. We're now rotating a periosteal flap Lars. That's an augmentation, further augmentation. Here's Gould's modification just to stabilize the ankle. Okay, so now moving on to the osteochondral lesion itself. Let's a summary just by saying recent meta-analysis showed that there's no superior treatment when comparing all of these techniques. So it's dealer's choice, and you have to make a decision based on each individual lesion. Let's talk about microfracture. Kai Mithoff was one of our residents and is still here, and this is just a schematic showing how the damaged cartilage and the calcified cartilage layer is removed. Then we're going to perforate with a right angle and healing through progenitor cells and fiber cartilage with this type 1 collagen. We'll do it arthroscopically. If you're doing these surgeries, you want to make sure that you have enough room for a posterior portal. So when you get that leg elevated, so you can come in from behind if you need to create a posterior portal to get at the back of the ankle joint. That's a really critical point. My indications for microfracture are shallow lesions. They're less than 1.5 square centimeters. It remains the workhorse in my hands despite the limitations we'll talk about. It is the most common procedure for talar osteochondral lesions in the foot and ankle community. It's simple, it's quick, it works hopefully through native progenitor cells, a shorter recovery time. As Andreas and I would talk about in the locker room, well, what's going to happen to that fiber cartilage long term? Does it work for larger lesions, and what does it do for the underlying bone? If you're lower down and you have a larger lesion and a more advanced lesion on the staging system, is this really addressing the pathology of the underlying bone? That being said, overall it has about 85% good, excellent results at 2 years. It allows early motion and weight bearing. You have worse results with ankle instability, uncontained lesions, and larger lesions, and functional results may decrease with time based on our concerns, our shared concerns on fiber cartilage versus hyaline cartilage. A recent study did just come out looking at long-term results of fiber cartilage. There are 83 cases at 10-year follow-up with an AOFS score of 85. Somewhat sobering, 43% of patients were pain-free, and 23% of patients had pain if they walked more than 2 hours. So you can look at that as glass half empty or half full, whichever you like. There was some increase in the arthrosis level based on imaging, and lateral lesions had better results. What else? Believe it or not, the Koreans have published on arthroscopy for cystic lesions. It doesn't make sense. I think you're just debriding the mechanical debris that's in the joint, and they have some studies saying that if you have someone who's older and doesn't necessarily want to go through a mosaic plasty or bulk allograft, you can scope them. Early weight bearing is okay in 2 recent series, and there is some early evidence to support the use of postoperative biological augmentation with PRP or HA, and those were both level 1 or 2 studies. So we're looking at that in the foot and ankle world. What if it fails? Well, then you can repeat the arthroscopy. Dick Ferkel has a series on that. You can then resort to pediatric cartilage or mosaic plastic. Moving on to osteochondral grafts, and these are obviously more structural. My indications for an osteochondral graft is a large or a cystic lesion, again, moving down the spectrum and the continuum of the osteochondral lesion. And this is where that slide on the difficulty of getting to the ankle and how it's it's a very tight joint. On the medial side, you do need a medial malleolar osteotomy. I'm sorry about the tattoo there, but the lower hand of the self-retaining retractor is on the osteotomy. And here you're coming in laterally on the slide in the lower right. And do we have a pointer here, guys? Okay. Yeah. So here is your osteotomy being flipped down. This is proximal, and this is the foot, and this is on the medial side, allowing us to get inside. And here now is lateral. So here's your fibula, here's your cuff of tissue. We've got a lamina spreader between a screw and the talus and the talus. And here are some plugs. Now, we're going to talk about this. This is more of a shoulder lesion, so you can see one of the shortcomings already of an osteochondral plug in the sense that it's difficult to address a shoulder lesion. So getting there, here's a clear picture of your medial malleolar osteotomy. You can see with this case is for a bulk allograft. Let's go back 1 second here, guys. And you can see how far you have to come in. So you want to bring that far immediately into the joint. You have to get the posterior tibial tendon released, and you have to not be afraid to go behind the ankle. But you can get pretty far medially or laterally with a good osteotomy, as long as you're not too shallow. We use a graft holder to harvest our plugs. Here's a difficult challenge, and these are frustrating. They're uncommon, fortunately, but when you have a central defect, how can you get there? Well, we'll just take a slot with an osteotome, come in through the front of the ankle, and then put your single plug in the center. Fortunately, those are common, but that's a difficult approach. So what are the pros of mosaicplasty? We'll talk about vertical integration. They're stable, they anchor with bone-to-bone healing, and so you're relying on the bone to heal the bone, which is best. Cons are you often have to do an osteotomy. There may be donor site morbidity if you're harvesting from the knee, or if you're using allograft, you have to worry about your chondrocyte viability. Also, as we saw on that slide, that there's a difficulty with shoulder lesions and perhaps some concerns with histocompatibility. So let's look at vertical integration, and looking right here, and I'll tell you guys about cartilage. I deal a lot with tendons, and to me, the enthesis of a tendon, or in our instance, the integration between one tissue and another tissue with the Achilles, you can take someone and lift them up by their Achilles and it still doesn't rupture. And that's amazing, where you have one tissue invading another tissue with that degree of strength, right? That's a limited form of cancer. When else do tissues invade other tissues? And if you say, I've got a tissue that's invading another tissue, you'd say, that's worrisome, that's a cancer. But you have this controlled integration on your left with the Achilles tendon, on your right with the cartilage, and that's just a beautiful thing in my mind. And mosaicplasty and these plugs, they take care of that. So here we are. Here's that shoulder lesion, which I don't think was so well reconstructed with this, but we might consider a bulk allograft. We'll talk about that next. Here's some clinical series on mosaicplasty. Hangodi had 94% good, excellent results at 2 to 7 years. These were autografts, and he didn't have any long-term donor morbidity. This is an interesting series that just came out with a very large series published in JBJS, very large series looking at sports, and 89% of patients were engaged in sports at their latest follow-up. To me, that's a very helpful statistic. If you ask me what's the difference between an 85 and an 89 on the AOFAS score, I don't know what it means. But if you say to my young patients that you have an 89% chance of getting back to sports with an allograft, that's very helpful. What about bulk allografts? Here you can see a bulk allograft, again, through a medial malleolar osteotomy. I don't know if Lisa's still here, but you can see the osteotomy here, some countersunk screws. Here's another graft, and you worry about that cartilage and the quality of the cartilage you're getting. This is in preparation where you have that shoulder lesion. You don't think a mosaicplasty is going to work here, so you need to go to a bulk allograft. Here's another lesion that we did through a medial malleolar osteotomy. We've got our pre-drilled screw holes here. You've got nice fit. We're going to secure that with a screw. You should be a little bit concerned about the difference in appearance of that cartilage versus that cartilage. These are obviously allografts. Pros of a bulk allograft, they're suitable for large deformity. They allow you to reconstruct that lateral wall if need be. There's no donor site morbidity. And again, it brings in that vertical integration. The cons are there's no good jig. And when we do the mosaicplasties, the specs and the tolerances on the jigs are really critical. And we don't have a good jig for this. So you're doing this free cut by hand. And I've spoken to some folks in the industry, and there's just not enough of a market in the ankle to have a jig, and you can't get the far wall when you're cutting it. You can make your cuts from the side and the bottom, but when you get that far wall, you're going to bump into the tibia, so it's always tough to do that. There's concerns about long-term survival, and it's a very time-sensitive procedure. Again, we spoke about vertical integration. Here's a lesion we did with cystic changes and needed a bulk allograft. And you can see here you have good fit here, but it's not always that clean. And what happens is when you cut these, if it's loose, you're in trouble, right? Because then you have synovial fluid getting in between your interface and impeding with healing. And if it's too tight, then you're really pounding on that cartilage trying to get it implanted, and you're worried about damaging the cartilage. So here are some clinical series on bulk grafts. 17 ankles with follow-up of 4.1 years. These authors had an 87% incorporation rate, yet you look, there was osteolysis and subchondral cyst and degenerative change, and 5 out of 17 were considered failures. Here's a larger series at 42 patients. Average follow-up is 37 months, and there are 10% graft failures with improvement in VAOS and AOFAS scores. I haven't seen long-term results of these studies, and this is where you have someone like Mark Swinskowski would call these folks and say, how are these patients doing? Let's bring them back. But in my hands, if you ask me about mosaic plasty versus a bulk graft, hands down, I'll try to do a mosaic plasty over a bulk graft, even if it means getting clever with your harvest and trying to incorporate some of the shoulder when you do your harvest to rematch that shoulder when you're implanting the plug. Or with some of these grafts, and we used to use femoral condyles, which aren't available so readily anymore, you could actually, on the curved side of the graft, you could harvest a shoulder and then implant it and solve the shoulder problem. So in my hands, if I'm deciding between bulk allograft and mosaic plasty, hands down, I'll go with the mosaic plasty. Okay, what about pediatric cartilage? We all know about pediatric morcellized cartilage. It's a single operation. You're bringing in young hyaline cartilage, and there's no donor site morbidity. What are the cons? There's limited published results. It's difficult to reconstruct structural lesions, although I'll show you some cases where I think that you really can do it, and I think that those larger lesions are one of the best indications for de novo, and then cost issues. So the vertical integration, there's talk about we put in this cartilage, it's high-level cartilage. Does it integrate like slides we showed before, and how long does it take? And there'll be research upcoming on that. The guys out back were kind enough to share some histograms here, and you can see that there is, on the slide on the right, some integration by at least 2 years. But that's one of the concerns is, will this cartilage, this high-level hyaline cartilage, actually integrate vertically, and if so, how long will it take? Indications for this are, in my hands, failed microfracture, large or cystic defects, and perhaps primary treatment. There are some authors out there who are going to pediatric cartilage as a primary treatment rather than microfracture, just because of the quality of the cartilage and of the cartilage that you have. Some further images. This is a case of mine that I think is a fantastic indication for pediatric cartilage. So you can see the large cyst on x-rays and very sobering on CT scan. You may have a small fracture in the back, but really what's critical is that lateral wall. So you can still see you've got this lateral wall, and so you have containment. Maybe not biology here, you have biology here, but you have containment here. This would be a huge osteochondral bulk allograft. And so with this patient, what we'll do, we'll fill with bone graft. We'll roughen up here, fill with bone graft up to here, a bi-guide membrane, then we'll put our de novo on top of that and fill the lesion. I'll show you some. This is that case. And you can see, you can't see the cyst because that lateral wall is intact, but there we are right before closing with the de novo, and there's the postoperative x-rays with incorporation of that bone underneath here, and then a healthy joint line. And that patient is still doing well, now several years out from surgery. This is Chris Coetzee's study looking at de novo for 24 symptomatic osteochondral lesions. These lesions, they had a wide range of size. So there were some smaller lesions in this series that may have been amenable to microfracture. There were also the larger lesions where you'd say, well, maybe I need to go to mosaic plasty for this. 14 patients that had prior surgery, so there was a bit of a selection bias for more challenging cases here. Their mean AOFAS score was 85 points. 78% of patients had good to excellent results. So pediatric cartilage certainly remains a good salvage following failed microfracture, as we talked about. I'm going to move on to ACI and MACI a bit, and I don't do these, but let me talk about them. ACI, we all know the pros: hyaline cartilage, the autogenous graft, the large defects, no donor site morbidity. The cons, that we're all aware of, multiple surgeries and costs. But in the ankle, it's a bit more technically demanding because it's constrained. And sewing on a periosteal patch in cartilage, it's 1.5 millimeters thick, and getting to the far side of that with an osteotomy can be difficult. Nevertheless, Sandro Giannini in Italy has published a series of 44 patients followed for an average of 30. Their average is 31 years. I think these patients were 4 or 5 years out. This is not short term. And patients were doing well at 87 months post-op. So 5 to 6 year follow-up, they had an AOFA score of 92, and the scores improved with time. Another series by a rather unfortunate name there, Dr. Quack. 29 ankles, average age of 34 years, 70-month follow-up, and AOFA score improved up to an 85.9. Yeah, that's nice. Again, the scores, 9 excellent, 14 good, 5 fair, 1 poor. And those subjective results, I think, are as telling as the objective results. Macy's just been improved. We'd have to look to Europe for some results. On Macy, it's a single-step procedure. And here is Victor Valderrabano, 24 months follow-up with improvement scores and the improvement in the AFS scores from 60 to 89. So in conclusion, all lesions are not the same. Think cartilage, think bone, be versatile in your approach. Think about instability, think about alignment. Most of my simple microfractures are performed in conjunction with a ligament reconstruction and sometimes with a bony realignment procedure. And we have several reliable treatment options for these cases. So that's a whirlwind. Again, there's no superior treatment. And thanks for having me, Tom. I hope that was helpful for you. The ankle is the ugly stepchild. There's not a single question. All right, Tom. So we put de novo on top. So we put the graft on with bone graft, and the de novo goes on top of that. Yeah, so that's my go-to. So the case I showed was bone graft and then de novo on top of that. And we don't have a large series, but half a dozen, so we've done that, and patients are doing well with it. Mike Wilson had a series where he did it without the de novo, and Tom, a third of the patients were pain-free. It was interesting. So you take care of one of the things you taught me is cavitation and collapse of the bone. And if you're underlying the bony problem, it's addressed. And again, in my hands, I'm looking at that bone as carefully as I'm looking at the cartilage. All right. Hey, Mike. Good to see you. Thank you very much.
Chris will be a tough act to follow. So you just bring out the first one, yeah. So I just want to talk to you today about cartilage repair in the hip, which has been very limited until the last few years, where we've been history-wise, where we currently are, and hopefully the future and where we're going. I have no disclosures. So looking historically, the way that we try to maintain these hip joints is really by removing loose bodies, doing abrasion chondroplasty, doing some limited microfracture, and also debridement. But I want to talk to you what a normal hip looks like, because it's a joint that a lot of times you walk into a doctor's office, you see every joint except for a hip, and especially the inside of the joint, especially when we're using a 70-degree scope to show the visualization. So I want you to take your left hand and make a cup like this. Take your right hand, put your fist in it, look at it this way as if you're looking at that screen. So where your fist is, it's a right hip, and that's where the femoral head is, right here. This is your acetabulum. This is your articular cartilage here. And I want you to remember this transitional zone. It's called the condylabral junction. It's extremely important. It's where I think the cartilage really starts to deteriorate to start arthritic processes. And then the labrum, and if you look at your hand that was a cup, that's your acetabulum. The labrum comes over it like a fish mouth. So it attaches on the inside and the outside. On the outside to the capsule. On the inside, it's a seamless transition between the articular cartilage and that labrum through that transitional zone of condylabral junction. And we'll talk about that because it's all type 1 collagen. It's not type 2 collagen. And we'll go over that in a little bit. So this is looking at that same hip, and if you took your hand again and you look directly at it like this. This is the ball back in the socket. There's no traction on. We're looking head on into it. This is your labrum, and look at that seal. It's kind of like a gasket on an engine. It hermetically seals that joint, so you have a relative vacuum in the joint. And all engines, including biological engines, work very well in a relative vacuum if you have some slippery fluid like oil or synovial fluid. When you have synovial fluid and you have a healthy joint and a well-sealed joint with a good labrum, the coefficient of friction is kind of like ice on ice. When you lose that labral seal or you have gaps underneath that are degeneration, it's kind of like sandpaper on sandpaper. So it's extremely important to try to maintain this labrum for the health of the cartilage. When you start to lose your labrum, you end up getting increased consolidation of the cartilage, so it gets a little bit firmer. And now it's subjected to compressive loads, it doesn't hold up as well. So it leads to deterioration over time. Gauntz really put us on our head when he described impingement with labral tears, in that anyone who scopes hips would think, well, I'm just debriding, taking out things, but now we had an opportunity to try to really prevent deterioration of the hip. And I really think that he came on to something that causes arthritis that we've been looking at for years. But as Dr. Ranawat would say, the eyes cannot see what the mind does not know. Until you hear it and you look at it, you think that's quite simple, but it's exactly right. And when you get to scope these patients, you see that lumps and bumps about the hip getting dragged into the hip and causing a mechanical abrasion, and then you see the results, especially when they're 15, 16, 17, 18 years old. You can make a big difference by taking off the lumps and bumps. But I think it's a little bit more complex than that. So this is the cam lesion, just right here, just decreases your head neck offset, and it gets dragged into the hip, and it ends up tearing the labrum here and delaminating the articular cartilage and pushing it toward the center of the joint. And this is what it looks like. So right there is your cam. This is the labrum right here, and you can see how frayed the labrum is here. And then as it gets dragged underneath, look what it does to the labrum. It lifts it up. Now you lost your labral seal. You lost that vacuum. It's pushing the labrum out away from the joint and tearing it, and then it's delaminating the cartilage and pushing it toward the joint. And if you look at the same patient inside, this is what you get. This patient's 18 years old. So this is a combined lesion, both pincer and cam, and most of our lesions that we see, they're over coverage on the cup and also a cam in about 75%. This is what it does. And in later stages, especially if they don't come in like a professional athlete, they will lose all their cartilage, and there'll be a clean delineation right here across the diameter, the equator of the hip, but yet the femoral head will still be in good condition. So it's in the late stages that the femoral head starts to deteriorate. So pincers are more common in females, and again with your hand, if you think about the gap that's underneath for you to move your hip, it just closes that gap down because it's rotated. So as you flex up your hip past 90 degrees, the poor labrum gets nutcrackered between the acetabular rim and the neck junction right here. The good thing is, with pincer lesions, there's usually not much articular cartilage damage. So if you look at this patient is 22. This labrum is split in half. This is the tail right here, kind of like a parrot beak tail, but the whole labrum is split in half. And this is from overcoverage right here. You can see that the medial wall right here, this is posterior wall, this is the anterior wall here. It's a medial wall sign where the posterior wall is medial to that anterior wall, and that's the overcoverage. Looks like a bow. So there's most of the techniques in the United States use this technique to take down that pincer. The problem with this is, number one, you're destroying the vascular supply because the supply comes in at the capsulolabral junction. Number two, you're now going through that chondrolabral junction. And I equate it to the equivalence of cracking enamel on a tooth. You can never get that tooth to heal. That enamel will always stay cracked. Once you violate that junction, it doesn't heal. That's where we need help from the guys that do cartilage repair, and the need to help us, and Dr. Minus, Dr. Kamal have been helping me with suggestions in the hip because it's much different than the knee. So that what we do now is we elevate underneath the capsule and underneath the blood supply, and we take that all the way out to the rim, and then we take a high-speed burr, and if you put it on reverse, you could take off that bone away from the labrum without decimating the chondrolabral junction and without violating it if they're young enough. Why? I notice in older patients that area starts to break down, and I get perforations even with the burr on reverse. So what's on reverse with a very healthy condylabral junction, healthy labrum, it's almost like there's a lot of elastin there because you can bump up against it and it doesn't tear, but later on it does. And so this is a technique here, just elevating the capsule. You can see the blood supply coming in here. And this labrum is very attenuated. So what we do is this also augments the repair so that when we put our sutures on, it doesn't pull through, and it usually holds up very well over time. And we've published this, and the patients are doing quite well. And it's alternative to taking this out, because if you're going to take it out and use an allograft, you've just destroyed that entire condylabral junction to take out a tethered labrum. So I think that you've got yourself into a deeper ditch. And this is just taking off this overcoverage right here and the cam, and this is what it looks like. So this acetabulum started right here. That was the rim, and what we did, we trimmed it back like this, and then we'll put the whole labrum back on. So the labrum is all the way out here. This off-white color, that used to be the acetabulum, and there's no perforations. This patient's 18 years old. You can bump up right against it and keep that tissue completely together. And then what we do, we put anchors in. The anchors have sutures. And that area, again, I swear I thought it was elastin. I thought, well, this is going to be an easy Capron study. So we did it with a goat. And we did 10 goats and looked at it. And the majority of tissue is a type 1 collagen. But this has not been identified before because it's a crimped collagen. It's crimped and relaxed, and there's a ratio of it. And I thought, now, why is that at that junction? And it's all fibrocartilage. It's not hyaline cartilage. And when you think of it, it's because of the shear forces, I think, that when you twist and move your hip, and it's so constrained, unlike the knee, you're stretching the collagen fibers in that cartilage. And I think if it was hyaline cartilage, it probably wouldn't hold up very well. So when we repair this area, if we go to stem cells or whatever we go to, we really want that to be a transitional zone of fibrocartilage, not hyaline cartilage. So this is the same thing. This is the goat, and it's 4.5 centimeters, a very small joint to work with. But these are pain fibers right here, the P substance. And you can see they're in the labrum, but there's a lot in that condylabral junction. So if you have patients coming in to be treated for impingement of the hip, and they say, I got an achy hip, 24/7, it aches me, unfortunately, that's usually why, because they've extended into that condylabral junction. And even if I take off the lumps and bumps and I repair the labrum, they still have an achy hip. And it's kind of like watching somebody work throughout the day and they got a headache. They're doing their job. They look fine. You say, hey, you look good. How you doing? I'm miserable. Why? I got a headache. I got a headache 24/7. Well, this is like a headache in your hip 24/7. So it's a big problem when that area starts to break down. And it doesn't go away. So this is just putting those anchors in. So we're back to this same edge right here. This is the area that we took the bone all the way back. And then we secure it. We try to do vertical matrices. I try to bring mine behind the blood supply. The main blood supply comes in at the capsule, and then we tie them on the capsule recess side so none of the knots are prominent. Now, look at this. This patient's a professional athlete, 22 years old. This is his hip, and this is how they come in because they're on contract. So what are you going to do with this? This used to be a labrum. This is a chondral flap here, but look at the head. The head's perfect. And then look at the tissue behind it. Very inflamed. So I think most people would just say, let's just debride it and we'll put in that allograft. The problem there is he's already violated his condylabral junction. To put in an allograft, you got to take all of this out, take the rest of the junction out. So we develop a technique of doing capsular augmentation, and it works very well. And what we do is we bring up 5 to 10 millimeters of capsule just above that area. So here's the edge of the cup, here's the labrum, capsule's up here. I elevate it and bring it down. So it buttresses the labrum and it augments it. So now when I put these loop sutures in, because you can't do vertical matrices in this stuff, you got to use loop sutures, it won't pull through. And it holds up quite well. And we have them out to 8 years now. And this is that same patient, and this is the chondral flap. So we started microfracturing these long ago because I learned very early, if you take these flaps off, if you trim it to a square shoulder, if you violate the calcified plate, these deteriorate very quickly. Almost in 1 year, the hip just turns to severe arthritis, and they need a total hip. So we started microfracturing these, and we noticed serendipitously, they're doing pretty well. I was sure that they would come back, and I would have to figure out what can I do next. But this generates their own endogenous stem cells and some fibrin, so that this would hopefully re-anneal and seal, but it does take a long time. They usually will have some symptoms for 1 to 2 years, and then all of a sudden it stops, and the x-rays are holding up. So this is the finished picture, and that was the same patient. And look, again, the femoral head is pristine. So this is what it looks like when you put the ball back in the socket. This is the same patient. Everywhere you see red, that's capsule. Everywhere you see white, that's labrum. So it gets very attenuated, but look at the seal. So we've restored our seal, and that's our goal, that not only to restore the labrum, but to restore the seal with no gaps. This is the same patient just doing the trimming, the same thing when you're taking off a cam lesion. You don't want right angles. There are no right angles in the body. The body will fill in any right angle. You want it to be nice and curved, just a very, very nice gentle curve, just like the normal hip would be. And the reason why is if you have a right angle, as you flex your hip up past 90, there's a gap. There's a gap that goes in because it's no longer round, and now you've lost your labral seal. So this is my fellow from, I'm not going to see who it was, of course, with the HIPAA, but he was complaining to me and telling me that he had the same symptoms, and by the end of the year he said, I hate to tell you this, but I think I have this. And I said, come on, it's just that you're doing a lot of these. And he goes, just do the MRI, big flap. So what are we going to do with this? This is it. So he's got a huge flap. He's got a labral debridement on top, or degeneration on top. And you think, well, if I take this off, I know that if I do that and do microfracture, it'll look good, it'll bleed well, it'll fall apart. It doesn't hold up. And anything that tries to grow here, because of the shear forces, will get knocked off and just won't take. It's almost like putting a young plant in soil, and every day you're going out and trampling on it. It just won't take because of the shear forces. So what we do, again, is we microfracture behind it. And this is a recent paper showing that there are viable cells in these chondral flaps and that they can survive and hopefully re-anneal. And this is just microfracturing that same patient. So then we said, well, who's not a good candidate for this surgery? Because everybody's reporting their great results, including in older people. And so we did a multivariate analysis, took 200 patients, didn't eliminate anyone, took them from 15 to 65, 132 variables, what your age was, whether you ran, what your BMI was, whether you smoked, drank, everything you can imagine, diabetes, it all came down to age. The only factor that was statistically significant was age. If we did them under 40, 85% were very happy with the results and back to their activities. Over 40, it doesn't mean that none of them did well. It meant there were no predictors. But over 40, if they had any cartilage wear, grade 3, grade 4, and a concomitant labral tear, they did terrible. So we are doing a level 1 study now. It's out 4.5 years. We select out of 3,500 now. We have 88 patients that we've done, and both groups did very well. It does look like there's a predilection now for crossover, which is quite high, is 50% into the surgical group, but they're doing well too. So I think if you have good selection, that we might still be able to help patients over 40. So where are we going now? So the biggest thing is early detection. You know, once you look like this, you're probably going to end up needing false teeth. Once you look like that in your hip, you're probably going to need a total hip. So I think there's just a certain amount of damage that we can deal with. And it's like almost like coming in, and I hate to keep comparing it to teeth, but coming in with a cavity and your dentist says, well, I'm going to clean your teeth, I'm going to get that plaque off your gums, and then I'm going to show you how to brush and floss. And you're like, well, what about my cavity? Well, there's nothing I could do about that. You know, we'll just try to save the rest of your teeth. And I think that's where we are now, is preserving, but I think we're getting a little bit of headway on the cartilage repair. So the other thing is avoidance of activities. They don't want to do squats, lunges, deadlifts. It's not the time to do the Boston Marathon to prove, like, she said I can never walk again. Look at me now, I'm doing the Boston Marathon. And then biologics, which I think hold a great amount of promise in the hip. So we can use markers to determine when patients are getting symptoms on their blood levels, but not pain. So we usually use pain now. We're not allowed to do this procedure unless somebody comes in and says, my hip's hurting. Why? Because it's coded as an investigational procedure, even with 3,000 publications. The National Institutes of Clinical Excellence codes every procedure. This is still coded as investigational. But with these markers, the inflammatory cytokines will go up, and we can tell that the patient definitely has some cartilage damage, even in younger patients. So we can pick them up maybe a little bit earlier. And then doing the surgery when it's applicable, but again, doing cartilage repair, not the same as doing it in the knee. And there's significant challenges. As you know, we just talked about the constraint, the shear forces, and morbidity. If you try to open these up and dislocate them and you end up with AVN, you're going to get into a much worse problem than what the patient had, and that's devastating if they're 18 years old. So these are the challenges. These are the current techniques that everyone here has taught us, including Tom, Andreas, Dr. Peterson. So these techniques are very promising. But in the hip, you can eliminate the top two and microfracture. If I microfracture any area where I see the breakdown, which is in that transitional zone, the condylabral junction that we're talking about, we've seen them deteriorate in 1 year. It just doesn't work. So you can take these flaps off and you microfracture it. But if I microfracture behind an already existing flap, they seem to do very well. So you have to leave what's there. Don't take it out. Then all these other techniques, we're looking at the BMAC, undifferentiated stem cells, and from what Lisa said, maybe that's the way to go. Maybe you don't want something that's already cartilage, especially in the hip. Maybe you can bring in the factors that you need and stimulate stem cells that are endogenous in the hip to produce what you want them to produce. And I think Lisa said it, and I've always said this, you can take bone marrow, you can take PRP, anything you want and inject into the hip. Nothing happens. Why? Because it's usually a chronic situation. The cells have no idea what you should do. And I think the reason why is because you don't have an inflammation from either trauma, and that could be surgical trauma, or it can be trauma from playing a game or sports. So these are the challenges we have that increase shear stress, and this has been proven significant at the periphery, and that's exactly where we're seeing the breakdown. Then that leads to a little bit of muscle weakness. Why? Because the pain inhibits the muscle. Then it inhibits the whole pelvic girdle. Then you get into a Trendelenburg gait. And when you do that, what happens is every time you take a step on this side, the other side drops down. Okay? So if you think of your ball and socket, you think of the muscles holding it up. And then what happens is you're taking the pelvis and it's dipping down. You're opening up my whole repair. You're taking the pelvis away from the repair. So we got into bone marrow aspiration about a little bit over a year ago. We have about 115 patients now. It is on an IRB. It's in a phase 1 study. We take the bone marrow and we're actually trying to get the stem cells out. So we centrifuge it right in the OR. And we do it from the ilium. If I try to do this from your iliac crest, my IRB would take about 3 years. As long as I stay where I'm operating, I can do this and usually get it approved, and that's what they did. So we take it from above the source seal right here, just off the reflected head of the rectus, right in the ilium. My repair, you see my sutures here? I'm up from that. But it's from the same area. So it causes, I think, a significant amount of less morbidity than if I go to a different area, especially, iliac crest. You do anything there, they complain about pain when they put their belt on. You get more pain there than what you started out with in the hip. So stem cells to me are like kids. You kind of have to guide them what to do. Who has to paint, who has to put in floor joists, and they have all this potential, but we don't know how to guide them. So maybe we don't have to use any blood products or anything else. Maybe the guidance is right there with the trauma, like Lisa said, but we are putting PRP, both PRP and PPP, so we mix it with plasma-rich platelets, and we mix it with plasma-poor platelets. And then we add some thrombin, and it makes a megaclot. So we centrifuge right in the OR, and Tom will tell you this, Tom Minus will tell you this. If I take this outside the OR, just outside the door, I have to go through the FDA. If I leave your endogenous cells in the OR, I could do whatever I want to them and give them back to you. So we centrifuge right in the OR, and then we give them back. And we have to aspirate 60 cc's of bone marrow aspirate, and especially in younger patients, it's very easy to get off, but we have no age limits on this, and our patients tolerate it very well. And then we mix it, and we add thrombin to it, and it makes a megaclot. And those stem cells are a very small part of that bone marrow aspirate, less than maybe 0.1%. Some people say even 1/100%. We're currently going to get them analyzed to compare the stem cells in the ilium compared to the stem cells in the iliac crest. And you'll see the stem cells coming in right there with the clot. And we put it over the whole area. The repair is all right here, and it just gives you a readout then. And it sticks. We've gone back in, so we take all the fluid out when we're putting this in. We don't want it to dissipate, but it hangs there. It really sticks like glue. And then that's what it looks like. So the summary, really in the hip, it's much different than knee. We really need early detection and treatment when it's indicated. Again, when it's indicated. Preservation of the labrum and junction, the microfracture, if it's behind a flap, I think it works. The stem cells, we'll see. I always question myself, maybe we do have to take them out of the OR. Maybe we need to culture them out a little bit more, but we don't know what the recipe is to guide the stem cells to do what we want them to do. But in a goat, in the Capron study, if you make a defect in a goat's knee and then you just close it up and you inject stem cells about a week later and then you go back in 3 months, you cannot find the defect. So I think you have to have some trauma, like Lisa said, that stimulates the environment, that sets up the milieu, where now the stem cells go in and they say, that's what they want me to do. Like when I show my kid his bed or I give him his toothbrush and say, I want you to brush your teeth. They need some guidance. I want to thank both Tom Minas and Andreas Gamal. They've been great friends. I really appreciate you inviting me to participate in your conference, and I hope that we have many more in the future. And I want to thank the audience for listening and for coming in on a weekend. Thank you. Yeah.
What are you doing with a positive wave sign with an intact transition?
Leaving it. You know, there used to be some videos out there taking a curette and taking it down to a sharp angle shoulder and then microfracturing those. They don't do well. They really don't. I think some wave signs are normal. I think some of it is that collagen that we talked about in that transitional zone is different than hyaline cartilage collagen. If anybody ever did construction, concrete is great. It's very hard, but it has no tensile strength. It's what you put in it. You have to put rebarb in it. And that's the collagen fibers. And to me, the collagen fibers for type 2 collagen, much different than the collagen fibers for type 1. Type 1 is very elastic, as we've shown when we take these acetabular rims down. Anybody else? So, and Andreas, I did want to say one thing. That's one of the slides got missed. I don't know why, but labral tears of the hip are extremely common, and I just told you how important it is. But once you hit your mid-30s, and there's 2 separate papers on this by Philippon and Schmidt, the incidence of a labral tear of your hip when you hit your mid-30s is 70 to 80%. It's really depressing. So then I wonder, well, where are all those patients that when they're 60 or 70, they should all be getting total hips, and they're not. So there has to be more involved in just tearing your labrum.
Scott, what do you think the incidence in the community of arthroscopic hip labral incision versus repair is?
Very high.
And what is significant? Is there any role in your mind of doing an excision versus repair, and what type of tears are involved with excision versus repair?
Yeah, I try never to excise. I mean, if you had a free flap, even on the bucket handle tears, if they're young, I'll put them back and I'll repair them. But we'll get a lot of revision surgery from outside. So the first time we do it, it's 85% success rate. Second time in our hands, maybe about 60. I think if it's from the community, probably lower than that even, because there's nothing there. And now you're into an allograft. And the problem with allografts, first of all, is you're dealing with an arc. So it's not just taking your IT band or your gracilis and making a new labrum, but you've got to make that go exactly where it needs to go. And my technique is I use the femoral head to show me where it goes. The femoral head guarantees me that when I reduce the traction, I let the femoral head push against the labrum, and it shows me exactly where that labrum goes. But that's very difficult when the whole thing is missing. It's tough enough when I have a huge tear, but I still have the labrum there. But if I bring out a labrum repair, do an IT band, bringing it in from the outside in, no, I have no idea except for that femoral head showing me where it goes. But if you have even a millimeter gap, it's not going to function.
Do you see situations when I do hip scopes, every now and then I get somebody in their 50s or 60s who had symptomatic mechanical symptoms. I go in there, the joint was pretty healthy,
Yeah,
but the labrum was just degenerative, like a
yeah,
degenerative horizontal fusion tear,
yeah.
meniscus, right?
Yep.
And you put the shaver on it, and basically the whole thing comes out.
Yes,
It's just so bad.
absolutely.
It's all the way, and they're very happy.
So we're very strict on who gets. So I learned the hard way that scoping hips over 40. That's why we wrote the paper. The results are so variable, and I would see patients that had mechanical symptoms. They say, if you just get rid of that mechanical catch, and I look and I go, they got a labral tear, but then in my head I would think, it's funny, it's not displaced, but they do have a grade 4 lesion, so they have something down the bone. And I hate to go back to the dental stuff again. It's almost like having a cavity. You had 32 teeth. If you have a cavity, you can eat around it, and you know there's a cavity there. I should get that taken care of. But every once in a while, you hit right on it, and it stops you dead in your tracks. And I think that's the catching that they're getting. They're loading it just the right way, especially when they pivot, that the pain fibers are stimulated in that area where they've lost their cartilage. So we're starting to grade our patients over 40, not on x-rays like everyone else is doing, like Tonus 2. Tonus 2, they've already got significant cartilage wear. We're grading it on MRI. So if they have full thickness defects, they just don't do well, Tom. And I agree with you. The labrums are different because I think their collagen is changing, not only at the labrum level, but also at that chondrolabral junction. If you put a shaver to it, there's no end to it. You know, unless you take the ultrasonic chisel, which is heat, and then you burn it. And I think heat is the worst thing for any chondrocyte. They're screaming for their lives when you put any heat in there. So we try not to use heat. Yep. Thank you.
So just to keep you on your toes, we changed the program around a little bit more. Owing to how important it is to get a good rehab together with good surgery, because this is really teamwork. All surgery is really teamwork between the surgeon, the patient, and the therapy team. So Kiet, who's Dr. Minus's PA, will give a talk over rehab after cartilage repair procedures. Kiet?
Thanks. So again, I'm Dr. Minus's PA. My name's Kiet. If you do a 120-minute surgery in the grand scheme of 3 months, that is 0.09% of the time spent in surgery. So that means the rest of that time is up to the patient and basically their rehab. So I'll be concentrating the majority of this talk on ACI. So again, that's a 2-stage procedure. The main goal of rehab for these knee surgeries is range of motion. We have to protect the grafts for about 6 to 12 weeks. And then I tell them they really need to get enough strength back to normalize their gait. So the general postoperative protocol, antibiotic prophylaxis, DVT prophylaxis, CPM, which I'll get into more, for 6 weeks, 6 to 8 hours a day, hinge knee brace to help with their partial weight bearing, the crutches, and then outpatient physical therapy as soon as possible. So again, different cartilage repair stages and different timelines. Basically 0 to 6 weeks is the early implantation. 7 weeks to 6 months, we're dealing with transition and remodeling. At that point, the cartilage is still really soft. Sadly, we have had to do subsequent scopes in that time, but you can probe it and it doesn't feel like the native cartilage. It's like a soft putty. And then 6+ months to up to 3 years is when it really hardens and kind of matures. So the main principles for rehab, don't let them get too deconditioned. We want to kind of do a core to extremity type of strengthening, glutes, and everything like that to avoid dynamic valgus both pre and post-op. So that's abduction of the hip and then that valgus force on the knee. And then we try to have them do that gravity assist dangle to 90 degrees as soon as possible. I'll get a little more to that later. Electrical stimulation for muscle tone and recruitment, and then patella mobilizations. We also try not to overload but not underload the grafts. They do need the physiological forces on them to help grow and integrate. Normal gait training by about 8 weeks, and then functional rehab, sports-specific rehab, 12 months to 18 months. So considerations for the ACI that can kind of change subtle nuances in the rehab protocols are the depth of the lesion and the graft, the location. Weight-bearing condyle is rehabbed slightly differently than a patella trochlea lesion, whether or not it's a bipolar lesion, and then that kind of dictates some of the open and closed kinetic chain activities. So range of motion, we start CPM therapy on day 1. It's 6 to 8 hours a day for about 6 weeks. The goal for range of motion is 90 degrees by 3 weeks, 120 degrees by 6 weeks. I tell the patients if they're sitting around not doing rehab to keep their legs perfectly straight, sit back, put it on the ottoman, or let it dangle over the chair, not sit anywhere in between. Basically, the reason we use the CPM is the stimulation of chondrocyte activity is induced by intermittent pressures. So CPM for the patella trochlea is limited to 0 to 40 degrees because 40 to 70 is the highest compressive forces across the patella. So we have them do that for 3 weeks, and then after weeks 4 to 6, we advance them to full range of motion. So what I tell them is CPM is 6 to 8 hours a day. Don't do that all at once, obviously. About an hour at a time, and then after that, dangle your leg off the table just like this, and then they can do their patella mobilizations at the same time. It's kind of tough to do your patella mobs in a CPM, but we want to make sure they get to 90 degrees as soon as possible. And this green area here is 60 degrees, and you can see, especially if the graph's right across the median ridge, any activity in that 40 to 70 early will stress the graft. Weight-bearing femoral surfaces. That range of motion is full passive range of motion again, and that CPM is starting at 0 to 40, advancing as tolerated for those 6 weeks. And then strengthening. So open kinetic chain and closed kinetic chain, I'm sure most of you know the difference. Basically, we like closed kinetic chain. It's more functional. There's co-contraction of the hamstrings and the quads, which leads to less shear, and it's a bit safer for the grafts. We do allow some open kinetic chain strengthening, basically a short arc quad from 0 to 30 degrees without weight, and then they will need the strength eventually to straighten their leg by themselves, which I'll get into a little bit more. And that's okay without weight. Good physical therapist told me about planks are a great way to do that core to extremity, and as well as do an isometric quad contraction. So that's a great thing to do with them. Terminal knee extensions with varying resistance. We do technically allow open kinetic chain strengthening after 12 months, but we don't recommend that for any ACI, especially if they've had a patellofemoral surface done. So terminal knee extension, straight leg raises for strengthening, and then bike with resistance when able. And electrical stimulation has a role here. People do atrophy quite quickly. So here is a video. This patient underwent an ACI to the patella and trochlea with TTO. So here she's riding the bike backwards. She's literally turned backwards on the bike and riding it backwards for some strengthening. Where did my mouse go? Here we have some monster walks side to side, trying to help avoid that dynamic valgus. Mouse keeps disappearing. And then we have some clamshells, some glute bridges with the ball. She does those 2 legs, single leg. This is an isometric quad contraction with some core strengthening, so another good one. She's doing that with 1 leg as well. And then we have some glute bridges, some Romanian deadlifts. Again, majority of this is closed kinetic chain. And then we have some dynamic core work here. I'm not sure what the bungee apparatus is exactly, but it looks like a cross between a TRX and something else. And then we have these squats. So this is actually not what we want people to be doing in about the first year. She's going a bit too low. But you can see she has the stim on there to help some co-contraction. And then just elliptical and bike with resistance for the majority of the strengthening. Weight bearing. So patellotrochlear lesions, 50% for about 6 weeks. Weight-bearing femoral condyle or tibial surfaces. Your touchdown weight-bearing, so that's just the weight of the leg for balance, another 6 weeks. Both of those we transition after 6 weeks. Our protocol says every 2 weeks you add about 1/3 of body weight, with the goal of 10 to 12 weeks being able to fully weight bear. That's usually done with the help of physical therapists and a scale. And then some considerations you need there for the deeper tibial and femoral lesions. Bipolar lesions, the ones that need to be bone grafted. About 50% of the osteotomies we do are performed with concomitant osteotomy. The majority of those are TTO, and then after that, HTO and DFVO. The TTO restriction is 50% partial weight bearing, but because we have to fixate the extensor mechanism, they have to wait 6 weeks before they can perform an active knee extension. They are allowed to do straight leg raises in the brace, but no straight leg raise without the brace for 6 weeks. And then all of these are full range of motion as tolerated. And it should be noted that the ACI surface takes precedence over the osteotomy, because again, you're kind of partial weight bearing for 6 weeks, so whatever osteotomy we do will heal, but it's the most restrictive protocol that takes precedence. So the activity, this is the part that patients always get upset about. They're limited for about a year. I tell them the first 6 weeks, all they need to do is bend their knee, get enough isometric strength to eventually weight bear after 6 weeks. They can spin on a bike when they get to 90 degrees, or it's around 3 or 4 weeks. So their good leg carries their non-operative leg. They start with the seat higher and then lower the seat as their range of motion improves. Anybody who's done CrossFit knows what that bike on top is. It's awful, but basically that bike you can pedal with your arms, and then you can just let your legs on for the ride. So if they have access to that, that's another great one. And the cardio workout you get from that hurts. Weeks 7 to 12, again, we transition their weight bearing, gait, and balance. And then the activities for months 3 through 12, essentially stationary bike with varying resistance, treadmill, walking, gait training, elliptical swimming, some isometric strengthening, ankle weights, straight leg raises, things like that. And then they need a lot of positive support to know that eventually they will be able to get back to some of the lighter sporting activities, that linear running after about 12 months, and then any cutting or pivoting usually occurs closer to the 14 or 18-month mark. Before we clear anybody to run, regardless of the surface, we have a follow-up MRI, and we want to see that there's no bone marrow edema. This is a fat-suppressed image, so the bone marrow is blacked out, and then any edema in the bone shows up as bright white. And that generally means that they're either overloading the graft or the graft is about to fail. So both of those, initially we'll try to treat them with pulling back activity and then monitoring with another MRI. But occasionally we will go back and scope them to see what's going on. And leg presses and squats are not encouraged in that 2-year window. After that, we do kind of cut them loose, but we don't actively encourage them to do that. Obviously, a functional squat like getting up the stairs and getting off the toilet is allowed, but that's functional. So this study just shows that basically if you have symptoms less than 1 year, 87% in that first study returned to 87% of the, let me rephrase that, 87% of those patients returned to play to their prior status at 4 years, but that's with symptoms less than 1 year. So this stuff does have to be caught early because it's only 33% with symptoms greater than 1 year. So the average return to play time or return to activity is slowest with ACI and OATS, but you can see here that they work better for the larger lesions, and they have the best durability of repair long term. So depending on how old your patient is, what activity they're trying to get back to, you kind of have to let them know that there are different treatment options. Other considerations, prior surgeries, potential stiffness, and then every subsequent surgery can lead to additional scar tissue formation. Our average patient has undergone 3 to 5 surgeries on their knee before they present to us. Scar tissue formation, we have started trying to use losartan off-label for about 4 weeks. I've started extending that to 8 weeks to decrease postoperative stiffness. I forgot his name, but a doctor in Colorado turned Dr. Minus onto this, and we've had pretty good results with this. There's the potential for subsequent surgical procedures. Again, that can be avoided with really good range of motion. And the age of the patient, and then an ultrasonic bone stimulator at the osteotomy site. I've started prescribing that for any double osteotomies we have. That's the TTO flipping up, and then the HTO or the distal femoral one, since it's such a large bone. So in summary, we have to optimize pre-op and post-op core to extremity strengthening, avoid that dynamic valgus, restore the patellar mobilization, that's medial lateral and north-south, So again, they can hang their leg at 90 to dangle and then really massage the gutters in, little circles up and down. Get that range of motion back, closed chain, functional rehab, and then we kind of progress them pretty slow. A little faster with the chondroplasty, microfracture, and oats, and the ACI and allograft. It's about 18 months to support specific goals. So some pearls. Range of motion is the most important thing, especially in that first 6 weeks. Stiff knees are painful knees. That core to extremity strengthening, closed kinetic chain is better than open. The grafts do require movement and weight bearing for full integration. And an ACI is the most restrictive protocol out there, so it's not an ACL we're rehabbing where you still can have normal weight-bearing surfaces and the graft will be okay. You're dealing with weight-bearing surfaces that if you overload them, can fail. Patients need a lot of perioperative goal and expectation management. Some of these patients, if we can get them to walk upstairs without pain, that's what they want. But, some of the higher activity patients, especially the younger ones, if they want to do heavy lifting and weights and stuff like that, we kind of have to talk them off that ledge. And then, again, bone length x-rays so that you can fix any malalignment issues. Any questions? Thank you.
Good. So failure of cartilage repair. How do we manage failure? So one of the big questions, this is more sort of a big picture question, is what you see actually a failure or quote unquote did the knee just wear out? And there's a little bit of a difference, more so to us than to the patient, because that determines what kind of revision options we have. So what does this mean? Let's say I do an ACI on someone who's 20, and they function fine, they live their life, and they come back when they're 35, and now they have pain again. So for a patient in that sense, the knee has failed him, so he has pain again. All that matters to the patient is I have pain and I can't be functional. For us, what matters is, well, did the ACI last for 15 years? The rest of the knee still looks fine. That area has broken down, and I can do another biologic intervention. Or alternatively, does the ACI still look good, and now maybe his lateral condyle has broken down for some other reason, and we'll add cartilage repair to the other side? Or has he now developed arthritis and we need to revert to something else like just an isolated osteotomy or a replacement? So it might seem esoteric, but the definition of what has actually failed and has led to this pain and dysfunction is important for us. Now, if you determine that it's not the rest of the knee that has fallen apart, if you will, but it's that lesion itself that was treated before, so what went wrong the first time? Because it's really hard to come up with a good plan if you can't figure out what went wrong the first time. So I'll go over how does cartilage repair fail, why does it fail, and then how do we manage failure. So how does it fail? Progression of disease I already mentioned. Your initially repaired defect is doing just fine, but there's more cartilage disease either adjacent to the repaired defect or elsewhere in the joint. You can delaminate the repair that you have. You can have some biologic failure, collapse, or pain. So this is an example of progression of disease. That's actually one of Tom's patients who was treated a long time ago with ACI on multiple surfaces. And you can still see the areas of ACI, and at some point I get a pointer. So there was one ACI done here, one ACI here. I think there was an additional one up on the trochlea. And those areas still look good, not perfect, but good. But the cartilage in between doesn't look good. So there was something genetically off with the cartilage that kept deteriorating over the years. And the areas that were treated, if you will, they were rejuvenated. So there was a new lease on life. So is it a failure if you get a 20-year-old another 10 years with their own knee where they can be functional? I wouldn't call that a failure, but that definition can sometimes be up for discussion. And this is one example in terms of progression of disease. So this is a patient who is an orthopedic surgeon. When she was in residency, she had her knee scoped, and this was just a tiny little tag. The rest of the knee looked fine. So that was treated appropriately with a microfracture. And I don't know if the next one shows up. So it was treated at the time appropriately with a microfracture. She was young, healthy, good alignment, good meniscus, focal defect, well contained. Yeah, you could have done maybe an autograft oats, but the two contenders were microfracture or autograft oats. This was done elsewhere. And then I think it was 5 or 7 years later, she had recurrence of pain. She hadn't done anything wrong. She was not a marathon runner, not overweight. But then her now partner, because now she was an attending, scoped her knee again, and this is what it looked like. So not only had the area enlarged significantly, but she had also developed lesions elsewhere in the joint. So this is progression of cartilage disease. She has something genetic, which unfortunately we cannot yet test for. But sometimes you do the right operation and it doesn't work. So how does that look? You can have delamination, and that's something that happens for any cell-based therapy. So you can have a repair tissue that grows, but then unfortunately something happens. I had a patient who did great until 7 months out, 9 months out after ACI. She went hiking, she jumped off a rock and had a little twist, and she felt something give her in her knee, and this is what this looked like. So she had good repair tissue, but then once you start playing with it, it hinges open. It essentially split right at the seam, and you can see how nice that tissue looks that grew. This is definitely cartilage. I sent that to pathology, and they said, this is hyaline cartilage. Unfortunately, it was not attached to the bone anymore, so it was useless, and she had to be revised. The same thing can happen to a certain extent with osteochondral allografts, where this, again, looks okay, but once you start playing with it, you can pull that cartilage cap right off. This is not the typical failure for allografts. They tend to fail more in the bone. This is more a delamination. But as you can see, both examples, good tissue, but since it's not integrated anymore with the subchondral bone, it's useless and needs to be revised. Sometimes, though, we don't even get to that. We don't even grow the right tissue, and that can happen mainly with the cell-based therapies. This is an example of a microfracture. Yes, there's tissue there. It's all soft. Doesn't really do anything functional. Even though on MRI scan it might look okay. So that's another example of why this would need to be revised. You have tissue, but the job is really to protect the bone, to help cushion the loads. And if that tissue is this soft, you can imagine it doesn't really do either. Sometimes it doesn't turn into the really soft fibrous tissue. It turns the other way, and that's a microfracture complication that we see about 30 to 50% of the time. I showed you those images yesterday. At least the CT scan here I showed you, where you can see almost like an iceberg how the bone comes up to the surface. When you look at these arthroscopically, they actually look pretty. They're generally fairly smooth, they're white, but they're solid and hard. The only time you see that, or the only way to really see that outside a CT scan, is intraoperatively if you take a spinal needle, and I learned that from Tom, and you just go into the tissue with the spinal needle, and usually you can bury the entire bevel of the spinal needle in healthy cartilage, but here you just get the tip in, and then you meet resistance because you hit the bone right under the surface. This is the same patient intraoperatively during his revision to ACI. You can see this is after debridement of all the soft tissues. This is just a bony mound, essentially, that remains. That's what an intralesional osteophyte looks like. Collapse is another way of failure. That's a failure mechanism for osteochondral, so either osteochondral allograft or autograft. That's how they fail. This is an MRI scan where you can see there are big cysts underneath the plug. There's still edema in the plug. This is a patient who got scoped after an osteochondral allograft, and his MRI scan looked fairly benign, but then once you start playing with this, the whole thing comes out. I think I showed you a picture. That's essentially like an OCD lesion. Unfortunately, not an OCD lesion that you could treat by repair, putting screws in, because this is allograft tissue. The body has decided it doesn't want it, but you can revise it. You can revise it either with bone grafting and an ACI, or you can do another osteochondral allograft. This is the most difficult that we all struggle with. If you have a patient who, with every single imaging modality, including arthroscopy, things look good. There's no edema structurally, there's no collapse. You do an arthroscopy and the tissue looks and feels fine, and they still have pain. And I have some patients that came in and they had a microfracture somewhere, they had the same pain, they get an OATS, they had the same pain. I revised them with an osteochondral allograft, and they say, through all those surgeries, I've had exactly the same pain. And I would assume that pain never really came from that defect. It might be some soft tissue pain, maybe they have a neuroma all along. So there is pain in the knee that's not structural, and we see that with anterior knee pain all the time. And that's not something we can cure with surgery. Ideally, we would be able to figure that out before we ever put a knife to them, but sometimes we just don't. These are frustrating patients. So now that I talked a little bit about the different types of what failure looks like, let's spend a few more minutes. Why does it fail to begin with? And there are different of these subcategories, and some of them we just can't avoid. They just come with the game, if you will. Others we could, with careful patient selection, where we are getting better. We read, we understand who is a good candidate for this procedure versus that procedure, or maybe they're not good for anything. And then some are specific to a certain procedure where we just realize, we've been doing this for a few years. We don't get the outcomes we're looking for. Maybe it's time to move on and pick something else. So bad luck. This is another patient that Tom semi-fondly might remember. This is someone who had a tibial tubercle osteotomy and fell down the stairs very early on and just pulled his tibial tubercle right off. That's not because of the surgery. This is just purely bad luck. Now we can try and make it as safe as we can. We give him crutches, we give him a brace, a locked brace. Just, if you wipe out, then at least it protects your repair a little bit. But at the end of the day, things happen. Bad patients, that's more difficult. So ideally, we try and weed out those patients. Now, we have patients who have unrealistic expectations. I remember this one guy who was able to run ultramarathons, but now he developed this fissure in his patella, and now he can only run normal marathons. And that was not acceptable to him. You never touch someone like that. There's no way you can do anything surgical that can get someone from a marathon to an ultramarathon. This is just something, I'm sorry, you just need to adjust your expectations. Other patients, they think they don't have unrealistic expectations, but they do too much too early. Someone who goes snowboarding after an ACL at 3 months. It's a stupid move. Their injury risk goes way up. What we all do, we never really talk all that much about that in conference, but we all do it subconsciously. We look at the personality and not just the knee. And there are many patients where we say, I probably could fix your knee. What worries me is the personality, the head that's attached to that knee. And I really don't want to invite you in my family, because as soon as I touch you, I belong to you, and vice versa. So there's a lot of that going in patient selection. So oftentimes residents or fellows come out of a room and they show you MRI scans and are excited and say, I think that's what we should do. What do you think? Like, I don't know, let's talk to them. And oftentimes the plan changes dramatically as soon as you have a chance to talk to them. Because sometimes they don't want surgery, or sometimes they want something that you're not willing to give them. The only help for that is counseling and careful patient selection. This bad cytoplasm, that's something we've seen. Someone who's morbidly obese, not just because they're heavy and put more load on it, but obesity changes the biochemics in your body dramatically. Someone who smokes, some people are just bad protoplasm, and that's not something we can help with simple surgery. And that goes back to patient selection. Just certain patients might be better off with non-operative management, because you don't want to put them through big operations if the risk of complications and failure is too high. This, I think, is we need to take ourselves to task a little bit over this. Orthopedic surgeons like toys. If something new comes out, we get bored with the same stuff. So we jump on something new, this whole thing. You don't want to be the last one on the bandwagon, but don't be the first one either. I think the second part of that sentence sometimes gets forgotten. There are many cartilage repair products that, as we heard yesterday, are in this allograft market. There's an FDA rule that you don't really have to do trials. Companies believe in their products, and I'm glad that they make new products because many of them are helpful. But there are some products that are on the market, and then we essentially do the research for the company. This, at the bottom, this green, was an interesting concept. It's an off-the-shelf osteochondral allograft, which is nice because there was a time when we couldn't schedule an allograft. We waited until a donor became available. And that's really hard to do for anyone. I'll need to be on crutches, but I don't know if that starts in a week or it starts in 3 months. So it was attractive. Unfortunately, it turns out that 72% of those plugs failed within a year. It's not so good. I would have loved to know that before starting to treat patients with it. So we need to be careful. So ideally, If you are in a community, if this is not your specialty, wait until Tom, me, Jack Farr, we'll do the failures and we'll tell you about it. But try not to be on that bandwagon, as I mentioned. And then bad procedure, that happens with all of us. Part of that is wrong procedure for the wrong indication. If you do microfracture in something that's 8 square centimeters in the trochlea, maybe it'll work here and there, but not consistently enough that it would do that to patients. So just like we do for everything else, just have good indications for your procedures. Just make sure that you have multiple procedures that you can offer, because every disease we have is a spectrum and you don't want to have just one hammer. You didn't address other pathology. You heard a lot about osteotomies, meniscus transplants, ligament repair. You need to look at all of that as well, not just at the little hole in the cartilage. And then how you do it for osteochondral allograft and autograft. If you really have to wail on that mallet to get that flush, the cartilage is dead on arrival. You might as well not have done anything. So now that you sort of know your decisions, how can you make it better? So you just go back to your cartilage treatment algorithm that you had for a primary procedure. So you look at the defect, you look at size, you look at location, look at the subchondral bone, is there edema, are there cysts, and then you pick whatever cartilage repair procedure is best for that. And then you also look at alignment, ligaments, meniscal deficiency, and you plan your concurrent procedures. So ultimately, revision doesn't have a significantly different algorithm. It's the same algorithm. You just need to be careful trying to figure out what failed the first time. So just one quick case. This is a 29-year-old. He had a microfracture medial femoral condyle 2 years ago, had a partial medial meniscectomy. Then that failed. He was revised to a fresh osteochondral allograft, had persistent medial pain, and even at 29, he saw, I think, 2 or 3 surgeons, and they said, only thing to do for you is a uni. I think one said a total knee, the other 2 at least said a uni. But what turns out, no one in this whole process had ever looked at his alignment, and he was in somewhat significant varus. If you're in varus and you have a medial condyle defect that puts so much stress on the repair, that's probably the reason why he had that defect in the first place, that the only thing he needed really was an HTO to address his alignment. And granted, the plug didn't look perfect on MRI scan, so I did a scope to get a little bit of a better idea. Is the plug okay, it's just overloaded, or is the plug failing and I should do the HTO and the allograft at the same time? But turns out I ended up just doing the HTO and he did fine. So that's an example where people had a little bit of tunnel vision. They sort of did the right thing for the defect, but they forgot that the joint around it had other pathology. So how do you manage failure? You get your diagnosis right. That's always the most important thing. If you don't know what you're treating, it's really hard to treat it well. Whether that's through an MRI, I use CT arthrograms quite liberally, arthroscopy. So if you can figure out what's structurally wrong, it goes back to some patients just had the same pain all throughout, but resist the temptation to just do something. And patients are frustrated. They want a fix. They come to you as a surgeon to fix them. Doc, just fix me. What could go wrong? Plenty of things can go wrong. And if you just go in for a fishing expedition, I think the likelihood of that being successful is very low. Sometimes you just need to tell the patient, I don't see anything surgical that can be done for you that has a meaningful likelihood of making you better. So I'm not going to do surgery. And then you hope that they don't go somewhere and have 7 additional surgeries and then come back and say, well, you were right. So set the right expectations. Sometimes activity modification is the important thing to do. So in summary, about 15 to 25% of all cartilage repair will fail. Unfortunately, we're continuing to do research trying to make that better. But first, if you have a failure patient, talk to them. What do they want? Some patients only want to know that they're not doing any further harm, further damage, and they can live with their pain. If that's the case, don't do anything else. Do they want another go at something biologic, or are they tired? Some come in and say, look, I've had 4 operations, just do arthroplasty. And sometimes that might be the right, sometimes that's the wrong choice. Counsel the patient that with revision cartilage repair, the success rate goes down a little bit. It's about 60%. And if you're heading down that alley, for sure, try and make sure as much as you can what went wrong. Just the same as if you revise an ACL. And oftentimes the problem is either the wrong procedure, so microfracture for something that's just too big or in the wrong location, or they forgot about concurrent pathology like malalignment is sort of the big thing. And if you can fix that, you, I think, have a good shot and a good patient. Thank you very much. Carl, I think you're up next. While this gets pulled up, any questions? The podium is all yours.
So what I'm going to speak about now is Tom wanted me to show how imaging can help you if you're trying to decide what sort of non-cartilage repair procedure you're doing. But at the same time, what it really is going to be a review of imaging cartilage and how we look at some lesions. So I'm going to try to show you some lesions that are relatively easy to see, and then also try to show you some that are a little bit more difficult, in the hopes that I can make each of you feel more comfortable about what you're looking at. So if we look at articular cartilage, it's a little bit more complex than other structures in that there's a lot of variation in the signal intensity you have. So you can see this tibial cartilage is all black, the femoral cartilage is kind of grayish here, it gets darker and it gets grayer over there. And that all has to do with the structure of it and the fiber angles of it. Because when you look at articular cartilage in this freeze fracture from Doug Goodwin, you can see that there's some very vertical areas and then some other areas near the surface curve. And for good or bad, MR is very sensitive to that fiber angle of the collagen. And that's when people talk about the layered appearance on imaging. That's what you're really looking for. And that's what you're going to be seeing in the images. The deep layer always tends to look darker because you've got all of those fibers and all that collagen tightly packed together. And any of the transitions that you see, though, really happen rather smoothly. So if you see an abrupt change in signal, that's usually a sign that something's not quite right. I think it's also important to know that depending on how you image and what type of image you have, that deep dark cartilage can look very thick. And if you look at the histology, the subchondral bone plate is really quite small and thin, and in general it's going to be a lot thinner than any slice thickness that we can get. Let's see if I go back. That we can get. So here's the same patella, and it's imaged with a proton density weighted image with a TE of 25 milliseconds. Sorry, I'm trying to get this. Of 25 milliseconds, and you can see how that dark area is, maybe a third of the cartilage, quarter cartilage. But if you go out to 130 milliseconds, it all turns black, and that's because you're out beyond where you've had all the relaxation of the signal. So don't assume that everything that's black is going to be cartilage, and I think that's important. But you can rely on the deep cartilage normally always being darker than the more superficial. So there are a lot of different cartilage sequences that we have, and you can see that depending on what you're looking at, whether it's a no fat suppression or fat suppression, it really can look quite varied. And let's see ahead. And so it can look brighter than the fluid or darker. And what you want to do is you want to be able to see the surface of the cartilage and also see the dark part of the cartilage or the deep cartilage and see those two interfaces. Here's another example where we have a short TE and a longer TE. And so this is the magic numbers TE for looking at cartilage somewhere in the 40s when you have no fat suppression on. And you can see how in the same day you don't see the cartilage defect here, but now you've brightened up the fluid a little bit. So you really need to look at all of your sequences, and if you see something that looks definitive, then go for it because it's probably the truth. These are the sequences that I like, fast spin echo sequences. I like to have a no fat suppression and a fat suppression so that I can see where that subchondral bone plate is and really get a true idea of the thickness of the cartilage. Deep cartilage can look very much like your suppressed marrow, as we can see there. And so that's a pitfall. And now we can get these 3D isotropic voxel images, and they're about 0.6 millimeter thin slices, and so that
really allows you to do a lot with reconstructions and that sort of thing. It's more like a CT than an MR, and I think those are very helpful. A lot of places don't do them because they take a long, really relative large amount of your time. And so that's why I think it's important for you to get in touch with your imagers and make sure they know that you're interested in cartilage and they might want to spend that time. CT arthrograms, as Andreas mentioned, are very good, and they have very high resolution, so you can see this defect with a lot more detail, and it's really harder to see when you've got a 3.5 millimeter thick slice, and so sometimes that's really helpful. And when we look at the cartilage injuries and the depth, this is sort of the modified outer bridge ICRS scale. They're all based on the thickness of the cartilage. We add also that there's abnormal signal, and we just don't quite know what it means. And you see that there's an abrupt transition here. So this is kind of a gray area for us. We don't know if this is damaged cartilage that hasn't physically lost its tissue yet, or what, and we don't know the prognosis of that either. But you want to have smooth surfaces, so here's a little bit of flattening in a patient that had a transient patellar dislocation. And then you can see a little bit thicker or more cartilage loss, a little thinner, and then a full thickness cartilage loss. And you want to look at things in two planes because sometimes you might have what looks like a big cartilage defect in one plane, but it's very narrow and it's really just a fissure. So when you're looking at the subchondral bone plate and cysts and you want to know how deep they are, remember that you need to look at where that subchondral bone plate used to be so that you can make that judgment rather than looking at it from the surface. So starting with some of the types of lesions here, we've got osteochondral lesions, and they may be empty. They may have a very thin bone plate on them. Or here with the fat suppression, you can see this is all bone marrow. It's thicker. So this can help you plan what type of repair you may need to do. I think one advantage that we have is we can see subchondral cysts beneath the surface that you may not be able to see at scope. And I know working with Tom and Andreas, where they want to be able to potentially bone graft these, I would try to tell them which part of the defect this might be in. It's in the leading edge of the defect or it's in the trailing edge so that they can find them more easily. So some defects are easy to see, and here's some examples where you have a nice deep fissure that's filled with fluid. You've got some fraying that looks like crab meat. Or you've got the osteochondral lesion with a big piece out in the back and it's empty, or full thickness defects. And I know sometimes it looks like there's a little bit of tissue there, but it's probably just some fibrocartilage or some fibrous tissue that's grown over it. Or like this patient that's got a meniscal insufficiency, a flattened condyle, a lot of sclerosis underneath it. So these are the ones that are relatively easy to see. And the key is that they don't have tissue in them anymore. And so that's, I think, what one of the things that I've learned is that spatial resolution and partial volume averaging is really our problem. So when you have a thick slice, you don't see all of those little details. So cartilage injury, you may have surface damage. So you've got an injury, you've got stuff coming from the top down, and that's when you get these fraying or these partial thickness cartilage defects. You may also have cracks and fissures, but I know Tom knows this patient. And what's interesting is we don't really see those cracks and fissures. But what we do see is we can see this bright areas down where at the base of the cartilage that I told you should always be dark. And so what that is that's delamination of that cartilage. And so when you have this relatively subtle finding on MR, and then this is the debrided lesion that you have, you can see that this can be challenging to understand what you're looking at. And just to show some other examples where you might have a cartilage flap, and no matter which I think of as a type of delamination that's going up to the surface. And so this may be an injury that's an impaction, but you get separation at the chondroosseous junction from the stress concentration. And here's an example of another example of a delamination. It's pretty easy to see this empty part of the defect, but what you have to understand is that this is going all the way back here. And so this is the true size of your lesion. And notice that the edema-like marrow signal kind of points you at that for some of these patients. Okay, another example of a delamination this was with a transient patellar dislocation. And then this one I thought was probably the most subtle one. This was a patient that had a successful cartilage repair, but then was having problems, and I stole my thunder. So here's this very thin line at the base, and this patient actually had a delamination without a communication, and Dr. Myas was able to move that cartilage over the bone, and this was the size of the final lesion. So those are the difficult ones. These are the ones that are filled with tissue, and in another couple of spots you'll see them with ACL tears, so it's easy to see this full thickness defect that you expect, but then there's a little cartilage delamination in the back there. So you just have to keep your eye out for that. And then you may have frayed tissue that just isn't in there, and we aren't seeing the abnormal signal. We're seeing a little bit of a surface thing, a problem here, but you aren't seeing abnormal signal, and then this could actually be probed down to the bone. So when you look back, you don't really appreciate this as a full thickness defect because it's filled with tissue. And this is where I think perhaps some of these things like T2 mapping may help you, because that should be abnormal from too much fluid around it. But because of the spatial resolution, we can't really see it. So damaged areas that filled with tissue, and just I would say maybe T2 maps will prove to be useful. And so sometimes that reaction in the bone is easier to see than the defect over it. So if I see this and it looks like it's a partial thickness defect, but because of this problem in the bone, I will say there's likely a full thickness component to that. And here's a real problem, because it looks like the surface is intact on this sagittal image, and you've got abnormal signal, so you'd say, oh, this is a grade 1 lesion. But of course, when you look in the other plane, you can see that these are fissures. And so when you superimpose the slice thickness, you can see that most of this voxel is going to be filled with tissue, with cartilage, but that little bit of fluid that's in there, there's a full thickness fissure, is causing this appearance. Okay, so these, I think of these as the blind areas where we have the curved surfaces, and we're doing vertical and horizontal images. You can see things there on the sagittal, but these ones are where you really should be getting more oblique images. So here's a osteochondral defect in the condyle, and it's hard to really understand what's going on here, but when you get this perpendicular image, you can very nicely see what you're dealing with. So I think that can be helpful. And this is Andreas's paper about the size of lesions, and I think that we do undersize them, and it's because we aren't seeing those cracks, we aren't seeing little separations at the bone plate. But if you look at where the marrow is, reporting this, I would say, okay, here's a delamination, but the edema goes further, so I suspect that this is actually a much larger lesion than you would expect. So how can we use this in determining what compartments are involved, so you guys can figure out what type of procedure to do? And so this was a patient, a 41-year-old male, and he was coming in. They were considering a valgus osteotomy for his OA, and imaging-wise, he doesn't have any real osteophytes or anything there. You can see in the medial compartment, cartilage is gone. This part of the lateral compartment looks okay, but as you image more, you can see that there's problems up in the patellofemoral, where he's got full thickness cartilage loss, a big defect here in the trochlea, and then also a defect in the lateral, full thickness defect in the lateral compartment. So this a patient, I believe, did not go on for that osteotomy. So here's another patient. This is a 51-year-old woman, had medial subtotal meniscectomy when she was 12, and so now it's about time for her to have a knee that looks like this. And considering, she's having trouble sleeping, stuck on NSAIDs, starting to take Prilosec so that she can take her NSAIDs so that she can sleep and all of that. And so the question is, can she have a medial unicompartmental prosthesis? And big osteophytes, and just the CT, which isn't necessary to do, but just to emphasize how large these osteophytes are. So does that mean all of the cartilage is bad? And you can see that her patella is really riding on an osteophyte more than anything else. And the answer is that when you look at this, the medial compartment is bad as you would think. The patellofemoral compartment isn't perfect, but there's only partial thickness defect there, no full thickness defect. And the lateral compartment, even though there are these big osteophytes, are fine. So she went on to have a medial unicondylar prosthesis, and they took away her osteophytes, and she's been doing quite well with all of that. And there was a paper recently came out that showed that 15-year outcomes in patients with lateral osteophytes, but without cartilage damage at arthroscopy who were having unis, did just as well as the others, no matter the size of the osteophytes. So osteophytes seem to be a reaction of the joint more than of a particular compartment, is what I think. So this is follow-up 2 years later. She was in the osteoarthritis initiative, so she got an MR of her knee, and you can see the lateral compartment really looks nice. Despite the artifact, we can still see that there's been a little bit of progression of her patellar cartilage, but interestingly, her osteophytes hadn't grown back yet. And at the last follow-up, she's getting some occasional patellofemoral pain, but no NSAIDs, no pain meds, sleeping through the night, and very happy. And then the final one, this was for patellofemoral unicompartmental prosthesis, and this is one that you know, Tom. And so he had a medial cartilage defect, and you can see that there. So this was not a candidate for a uni. And just to remember that CT arthrograms, as Andreas was saying, can be very helpful, especially if you have somebody like this where you want to size how much bone you're going to be missing when you go, or need when you go do your procedure. So I hope that is some practical help for you seeing these lesions, and thank you very much.
Do you have any questions from the audience for Carl? So one of the amazing things that I realized with MRI scans, everyone goes for field strength. And yes, you don't want to have some 0.2 Tesla extremity scanner, but we have a 1.5 scanner out in Chestnut Hill, and to me it's much more important what sequences I get than whether it's a 1.5 or 3 Tesla scanner. So sometimes we get outside films on a 3 Tesla scanner and I can't see anything because they have T1, T2. That's just not good enough. So, but the good thing for you is if you have a 1.5 Tesla scanner, as long as you tell the radiologist or the techs which sequences to run and you can talk to us about what that is, you can get great cartilage imaging from a 1.5 Tesla scanner.
Absolutely. And I would say that's the only reason that I know about these things is because I work closely with Tom, and we would go over every case, pre-op and post-op, and I would see all the great scope pictures that you saw that none of my colleagues have had the advantage of having that. And so that sort of communication with your radiologist, I think, is important. And if you can get somebody excited about what you're doing, that back and forth is really going to help out. Because a lot of times we're sitting in a dark room, and we may or may not know what you meant by, what comes through to us isn't what you necessarily wrote. It says generalized pain, and unless we go to the electronic medical record, we don't know what you're looking for. And so a lot of times that's where the communication fails. And I think that finding a good group that's interested is the key.
Is that how Cleveland looks?
This is Cleveland in the summer. You
Nice.
should come out.
It's very pretty. Good. The next speaker will be Dr. Wolfgang Fitz. He's an arthroplasty surgeon. He's been a friend and a colleague for many years, and he will talk to you about motor failure in young patients.
Thank you so much, Andreas and Tom, for inviting me. I feel a little bit an outsider here. I'm really not dealing with live tissue more than with metal and plastic. So I have really no relevant conflict here. So I do feel a little bit like the junkyard master here. And it's a little hard, but despite being a junkyard master, we still have like the feeling that we want to deal with everyone, like with this Mercury comet from 61. I'm still interested how this guy is going to do. So I'm going to talk a little bit about what are the failure modes in total knee replacement. Can we actually predict or select patients who may fail? You have a lot of young patients. What is the impact on survivorship? Are there any differences? And I will give a little few interesting papers that were published in the last couple of years that may change a little bit your perspective in how you deal with your failures. Well, what are the failure modes actually in total knee replacement? Here is a analysis from the Australian registry, and you see in green on top the most frequent failure mode is loosening and osteolysis, followed by infection, by femopatellar pain, which is related more in Australia to non-resurfacing of the patella, which we don't have here that much, overall pain and instability. So these failure modes will follow you throughout the entire literature. So the important thing is really aseptic loosening, infection, and pain / instability. If we look at different registries, this is true. So it's always aseptic loosening, infection, and pain. These are the failure modes you have to deal with. Here's a study, a multi-center study here in the US by Adolf Lombardi. He looked at 844 revisions between 2001 and 2011 over a decade. And he saw aseptic loosening, as we heard, instability and infection. There were still like some polyethylene wear issues, which I think are getting less and less. Arthrofibrosis, yes, we do see that. Sometimes it's in the bucket of pain. And malalignment, I don't think, is a major source of infection at this time. Interestingly enough, the mean failure time was 6 years. So if the knees fail, they fail relatively soon, and you see 35% of all the revisions occurred within 2 years and 60% within the first 5 years. So it's really a problem for these young patients who get their total knee replacements if they fail, because they have the failure early on and not 20 or 30 years later. Here is a paper by Delanoy who looked at the National Implant Sample Database between 2009 and 2013, a total of over 300,000 total knees. And you see again, infection and aseptic loosening are the main reasons for early failure. So it is also clear that age plays an important role in the registries for failure modes. So, for example, in the Swedish registry, you see that patients below 65 years have twice the risk compared to an older group of 75 years and older. Similar results out of the Australian registry. 4 years after surgery, patients below 55 have a 4.5 increased risk as compared to patients that are 75 years and older. And men have a discrimination here because we have a higher risk. England, Wales, Northern Ireland registry shows that the cumulative risk for revision in men over 75 years is 2% at 10 years. But men below 55 years, it's actually 12% at 10 years. And a large multi-center study for every 10 years of age overall, the risk of failure is decreased by 60%. I apologize for this little unsharp image, but that's the conversion from a Mac to a Microsoft, so best greetings from these colleagues over there. Here you see, this is actually also an interesting image, and this is again the England, Wales, and Northwestern Ireland registry, and it just is the cumulative chance to failure and the development over the last 10 years here between 2003 and 13. And you see that the failure rate overall hasn't changed much. It's maybe we get a little bit better. Here is a cumulative rate of revisions from the Swedish registry over decades. And I think this is kind of a little more interesting. They compared here 76 to 85 in green versus 86 to 95 in blue, and then 96 to 2005 and 2006 to 2012. And you see, despite the increased rate of total knee replacement, the revision rate is, thank goodness, relatively stable. And you can see overall it is more or less a failure rate of around 5% at 10 years and somewhere around a little bit less than 10% failure rate at 20 years. So that's very positive as compared to where we were like 30 years ago. Does the failures change? Will they change over time? And here's another paper from the Norwegian Arthroplasty Registry comparing the 90s with the 2000s. 10-year survival free from revision improved in total knees from 91 to 94%. And I had to actually add the results for partial knee replacements here, because the partial knee replacement in the Norwegian registry has a 10-year survival rate of 80%, and it only increased to 81% from comparing the 90s to the 2000s. Younger age is a risk factor for early failure. Here you see from the Finnish arthroplasty registry over 32,000 total knees, and you probably won't be able to read this, but this is like 40 years up to 80 years, and you clearly see this is at 6 years here, 4 years, that the younger you are, this is below 40 years, below 45 years, 55, you see the revision rate dramatically increases for total knee replacements. Here another picture, you see the same trend that older patients here in blue have a much higher long-term survivorship compared to young patients. So this is actually pretty scary that young patients below 65 and more so below 55 have really a dramatically increased risk of failure early on. Other question, is there a difference between males and females? And yes, there is. We are again discriminated. We males have a higher failure rate as compared to females. This is pretty interesting. I show you in a few minutes some controversy about why actually females also have, in a special collection of patients, an increased risk. The question that I'm going to throw out here is, what about HTO versus unis? And I think this is a pretty important paper coming out of the Mayo Clinic. They looked at patients 55 years and younger and compared the results of HTO with partial knee replacements, and they went for the activity score and survivorship free of revision. You see they had over 15 years between 98 and 2013, 240 patients. You see the mean age in the HTO group of 57 patients was 43, and 183 patients who were 49. And you see pre-op Tegner score of 3 and Lisholm score of 69. And post-op, the uni group had a thickness score of 3.8, but the HTO group only 2. And this difference actually persisted throughout 2 years, 4.3 versus 3.8, and also at the ultimate follow-up at mean of 5.8. You see that the activities, the thickness score is higher in the uni group compared to the total. And the survivorship also is lower for the HTO, 77 versus 94%. Another controversy is the wide use of femopatellar replacements. Here, a meta-analysis of 10 studies. 10 are actually level 2, 29 were cohort analysis. A total of 938 femopatellar failures in that meta-analysis. And the failure mode is clearly the progression of arthritis in 38%, pain 16%, loosening and maltracking 14 and 10%. While pain was the failure mechanism in the early revisions, arthritis is the main failure mode later on, and it's pretty scary, in my opinion, that at 5 years the failure rate for PFA in this large meta-analysis was 46%. Metal sensitivity. We all face that, you less than me, since we put more metal in. We know about adverse tissue reactions that are possible with metal, aseptic loosening, and revisions. And here is a study comparing 1,000 males with 1,500 females. They did in vitro testing for metal sensitivity, and the females have a much higher metal sensitivity compared to males. And this is just very interesting, which was just recently published in JBGS, comparing the same implant, one with a ceramic coating and the other one regular chrome cobalt. And at 12 years, the cumulative revision rate was 4.8% for the chrome cobalt component, but was almost twice as high for the Exinium implants. Kind of very interesting. Another issue that we all face is obesity. What can we do? Here in Tom Fairing's paper, he looked at over 1,000 revisions, and they had a total of 35 medial tibial collapse with more than 10 degrees of deviation of the component. You see that it's related to obesity. 95 out of those 35 had more than 200 pounds and 17 more than 250 pounds. And half of those implants were actually small on the size that were put in. So he concluded use actually stems in the implant. I don't do that. I would just recommend, and I show you that video because hopefully you also do some total knees, use a good cementing technique. Coat your implants as you see on the left. Use a less viscous cement because you get better penetration as if you use a high viscous cement. And you see my assistant has a little cannula. I use vacuum to suck actually the cement in. I let this. There is no really rush here at all. I take my time, and that's better if you have a less viscous cement to really make sure that you get a cement mantle, and we want about 3 to 5 millimeter of penetration. If you have less, you don't get the fixation. If you have more, you get thermal damage. Now, I went through the last 100 revision cases I did and took like some of the young patients that failed. And typical example is here, a 52-year-old female. She's 2 years post-op, had pain ever since surgery with a limited range of motion from 0 to 90. And this is like the typical patient that I see, and the type of revision I do for these patients, I call it a primary revision. So I want to try to get minimal or preserve as much bone as possible. Don't do any major releases. The workup always includes a CAT scan, and in limited range of motion, most failure mode, in my experience, is actually malrotation of the tibia. We don't know how much can you tolerate. I think it's individually different. There are too many factors. But if the tibial component, like here, you can see it's at least 40 degrees interrotated compared to the center of the tibia tubercle, that is an indication for revision. And I try to, here I got a little bit too much cement in the tibia, so I apologize. But I try really to minimize the stem. I use cemented short stubby stems. They're relatively easy to get it out if there needs to be any revision. Another example, 56-year-old male, 1 year post-op after his bilaterals, persistent pain, stiffness. You see the AP view, and you see the CAT scan again. That's actually a little bit more than 40 degrees internal rotation. And you revise it, correct the rotation, and they're pain-free. Next patient here is a 48-year-old with a rotating platform, has also pain ever since. I think in young patients, that if specifically you can see here, the polyethylene is determined by the size of the femur, not by the tibia. So the polyethylene is a little larger than the tibia component, so you get more soft tissue impingement. And I think specifically young patients don't like that. Here you see the revision, and of course afterwards he wanted to have the left knee done too. Another example here, 55-year-old male, 1 year, total knee. This one is instability, knee buckles, cannot walk stairs, and bringing the joint line down and increasing the posterior offset. The patient is now stable and pain-free. Here's another case that I wanted to throw in for all those who generously do PFAs. Here, a year after the PFA comes to me with that X-ray, and I'm like, well, in a year? That's kind of interesting. Well, you see bone on bone. However, I found some X-rays from 2008, and in 2008, actually, the patient had at least Kellgren 2 medial osteoarthritis, so no wonder that. So, take-home story, map your cartilage and make sure that you do the correct indication. Last case is just wear-related here, 46-year-old, over 10 years after a rotating platform with the asymmetry in her right knee. You see there is actually an osteophyte that never was removed that actually destroyed in flexion the posterior medial aspect of the polyethylene. And in this case, I took the osteophyte off, changed the liner, and the patient is up and going, and the swelling is gone. So I just want to throw 2 more slides in regards to also Carl's view now from an arthroplasty surgeon's view. So those are my X-rays for screening. You see standing views and Rosenberg views to identify either medial or lateral OA. I do a standing lateral view to judge the integrity of the ACL, and I do a skyline view to judge somewhat my PFA joint, and then I do a CT arthrogram if I think that's a candidate for a partial knee. And the CT arthrogram I've been doing now since 2010 has become really my stronghold for indicating whether I should do a partial or not. And specifically, since the resolution is so much higher, the slices are a millimeter instead of 3, you really can see every fissure, so I highly rely on that. Is there anything new? Well, I've changed actually practice in treating my acute infection, since infection is one of a major failure mechanism of total knee. 6 months ago, when we tried to set up a multicenter study of major academic institutions here in the U.S., looking into whether we should compare just simple washout with a 2-stage washout within 7 days. And so talking to Henry Clark, a friend of mine in Scottsdale, he convinced me not to do it for ethical reasons, because they published already a paper back in 2010, and he has now over 120, and the eradication of infection with this acute washout twice within 7 days has reached 90% in his protocol. And so what you do is you do a synovectomy, an IND, You take the liner out. I sterilize the liner in a highly concentrated betadine solution and put antibiotic beads in it. Close the wound, keep the patient in the hospital for 3, 5, or 7 days, and then go back in, do again an irrigation debridement, remove the beads, and then put a new liner in. Why not a new liner in the first procedure? Well, cost. It's much cheaper just to keep it and it's sterile. And since I've been doing this, I really noticed the second washout is a dramatic change from what you see when you go in an acute infected knee. It's amazing how just a few days with antibiotics, specifically the beads, how much better the joint looks. So in summary, those are the most difficult patients that are 55 years and younger you are dealing with, but unfortunately they have also the highest failure modes for a total knee. In my eyes, malrotation is actually a big component from a surgical perspective. Infection, not so much. I don't see too many of those. I would agree with you, be very thoughtful where you consider a total knee in those young patients. Be a little bit aware about the controversy of metal sensitivity and use good imaging techniques to diagnose really, is it a 1 or a 3 compartmental arthritic disease. Thank you very much.
Questions for Dr. Fitz? Jack, do you want to find your way up front? While we change, can we get the tibial tubercle osteotomy vignette, please? Wolfie, before you go too far, just one question. Wolfie? He's busy. Wolfie? Yeah. Just one question. Do you have any, I sort of know you don't, but what's the age limit where you're really uncomfortable doing a uni, a total?
I don't think there's an age limit. This year, my youngest total knee replacement patient was 22 years old. I think it's more, you have to be aware, the activity level I think is more important, heavy laborers versus I should send the patient to you for an HTO or not. I think key is really that you do the first procedure really well. You try to preserve as much bone as possible. Be aware that we know from the registry data, for example, that the worst long-term failure rates of total knee are in PS knees without patella resurfacing, and the best are with CR knees where the patella is resurfaced. So I like to preserve bone stock, so that's why I like to do CR knees in these folks. I don't use rotating platform because I think in young patients there's too much going on in the knee. They don't like it. The pivot point is wrong. So trying to restore the functionality of the knee is very important. And I think in the next 5 years what you will see that specifically high activities such as deep squatting, stair climbing, they will shine more light. Why actually are so many patients dissatisfied with total knees? Because they cannot do these high activities. So I think that plays a role. And that's why unis are much better, because they can do this.
Thank you. Jack?
So as a disclosure, Brian and I helped design this technique. Can you turn it on, please? So this is going to be more extensile. The reason for that, typically you're doing this in combination with cartilage restoration. This is a lateral lengthening. John Fulkerson, when he originally described anterior medialization, did a lateral release, but it's equally well done with a lateral lengthening when you can maintain control. So you're elevating the anterior compartment musculature from the lateral wall of the tibia, placing a guide to protect neurovascular structures. And I know Tom does these freehand, as many people do who are experienced. So I think certainly for those that are setting out for the first 5 or 10, these jigs are somewhat useful. Either this one or there's another commercially available. This pin has to be perpendicular to the posterior wall of the tibia to be accurate and be able to set these guides. This is a 60-degree guide. There's going to be an article coming out. Beth Schubenstein actually used this jig in the lab, and instead of 60 degrees, she thought it was, they measured it closer to 55 degrees, and in some cases even as low as 45 degrees. I think one of the problems you can have, you're not to the full posterior wall. So once you have the jig in place, you're just using it as a captured saw guide. You want to make sure you see the saw exit directly on the retractor. And then that's all that the jig is used for. So now you need to make distal and proximal cuts. So you're using the cut that you've already made as a captured saw blade. So now you're going to go distally. And you can see you're angling lateral as you're going distal so you can feather out. And then as you go proximally, you just cut to the edge of the patellar tendon. Unfortunately, I had a case referred to me in which they made the cut all the way in to the joint line and cut the anterior horn of the meniscus. So it's important to stop right as you see the patellar tendon. I usually use an Army-Navy at the level of the bursa that is immediately behind the tendon. So there's the saw going up, and we stop adjacent to the patellar tendon attachment. And then you have two other cuts. One is lateral, and you can do this with an osteotome or a saw. In this case, using an osteotome, and it's important to go from posterior to immediately adjacent to the patellar tendon and then switch angles, because if you continued, you go all the way up into the joint line. So there's the posterior cut, and now we're going to connect that. And then we switch angles, and now go actually from lateral to medial, just proximal to the tendon attachment. And then that will free your pedicle. And you can see you have a broad cancellous bed that will heal typically quite rapidly. So non-unions are extremely very rare with this type of procedure. And it's important when you're doing the fixation that you have it just like with any fracture fixation, you're going perpendicular to the line of the fracture or the line of the cut. And there we directly measure medialization and anteriorization. You can go ahead and turn it off. It's just putting screws in. Any questions?
Can you comment how often do you do a TTO together with patellofemoral cartilage repair? Is it in your hands I do it every time, or what are your criteria?
So I measure TT, TG, TT, PCL. I look at the axial alignment, and I watch the patient. I try to understand why they got to the OR. And based upon that, in what we've published, most of my patellar cartilage work is panpatellar. And so it's about 80% of the time they're going to have some type of elevation or anteromedialization.
Can you put the next talk on, please?
That is important because many of these patients, they've had a long history to get to where they are, and it's not even a fat pad anymore. It's really a dense fibrous tissue. It's almost 2 millimeters thick in many cases, and so I will approach it as I'm doing my lateral lengthening. As I go down to the level below the joint line, I'll just continue with cautery all the way across and release it. And then when I'm going medially, I'll come medial and release it, because many times, even though you've got the tubercle off and you're ready to flip the patella, you can't flip the patella because the fat pad / scar tissue has it bound down. So I agree with you completely.
You heard yesterday about HTO, so this is another brief overview with some videos. So there's a 37-year-old male, persistent left knee pain instability, had an ACL tear and a meniscal tear over 20 years ago, was not treated, and presents with essentially a chronic ACL instability, varus malalignment, cartilage defect. This is a case from earlier this week. Ended up being treated with a high tibial osteotomy and osteochondral allograft and then an ACL reconstruction. So he's in about 6-7 degrees of varus. You can see the arthroscopy picture. He has a medial condyle defect right here. The meniscus was small. He had a tear many years ago. This is his chronic ACL deficiency. Now, for opening wedge, the one thing I would say in general, and that's not limited to HTO, but always think about who comes next, who comes after you. So whenever you make incisions, just make sure they are incisions that somebody else can use for what the patient likely will need at some point. So if I do an HTO or a TTO, my assumption is at some point that patient might need a total knee. So I don't want to do weird hockey stick or transverse incisions that make life for the next surgeon really difficult. So most of the time, these are midline incisions, or at least close to the midline. You can cheat a little bit medial, cheat a little lateral, but always think, could I do a total knee through that? And if the answer is no, then maybe do a different incision. In terms of how to handle the medial soft tissues to get to the bone, there are different ways. Tom yesterday showed how he peels off the MCL and brings it posteriorly. I peel off the pes. That's what these 3 pictures show. Essentially, you have the pes incised along with the fibers. You can see the MCL underneath. The forceps hold the pes essentially away. And then I cut it at the insertion. I L it like you do for a hamstring autograft harvest, and I reflect that posteriorly. Then I can see my MCL. This is a video. It's a different patient, but same approach. Long incision because there was some intra-articular work to be done as well. Of course, that disappears. Then you start going posteriorly. That's probably the most critical part. You want to make sure that you protect the neurovascular bundle. If that's protected, then not much else can go wrong. So I incise the fascia at the posterior aspect of the MCL. You just follow the MCL, and then you just stay on bone all the way around until I can put my finger in. Generally, it doesn't require all that much sharp dissection in the back, so usually it's just about 1 centimeter to maybe 1.5 centimeters of the popliteus that attaches over the medial posterior border of the tibia. Once you're through that centimeter, and you can see that if you have the leg in a figure of 4 position, you can see that really well. And you just pull it away from the bone with your bow view, slowly go through the fibers, and at some point there's nothing attached. You stick your finger in, and you can just wiggling your way over, feel the fibula head all the way on the other side. And once you have that, you stick a retractor in and you're safe. This is something I learned from Tom many years ago. I like biplanar osteotomies for 2 reasons. So biplanar is you make a countercut behind the tibial tubercle, and that allows you to make your osteotomy cut itself more distally. That allows you to be farther away from the joint line, so the risk of breaking into the tibial plateau is lowered. You also, since you cut the MCL, the farther below the joint line you are, you only really cut the superficial MCL. You don't mess with the deep MCL, which gives a lot of stability. And you're not only farther distal medially, but also laterally. So if you have a lateral hinge fracture and you're a little bit more distal, you have enough proximal space to put a staple, a plate. You can do almost anything now that you have some good proximal bone. So how do you do it? It's almost like you do a tibial tubercle osteotomy. The tibial tubercle is anterior here. There's a retractor behind the patellar tendon. and you just come right across, just for a centimeter or a centimeter and a half. Alternatively, you can just peel a little bit of the patella tendon off and get more distal this way. But what I like about the biplanar, and here's an x-ray post-op where you can see this anterior cut, that is essentially always primary bone-to-bone contact. Since you only slide that distally, that heals pretty rapidly and gives you anterior stability. It also gives you stability from rotation and flexion and extension. So it gives you a little bit more stability and also visual reference when you open it up. As long as that only slides, you know you're safe. If it starts gapping in some weird direction, you know you're doing something funky with rotation or flexion extension, and then take more x-rays. Just make sure you know what you're doing. The surgery then itself, I put a guide pin in across, and as you heard yesterday, you want to aim for the fibular head. You don't want to come out here, because should you get a hinge fracture, then it's very hard to repair that. You also don't want to come out down here, because the bone starts to get really cortical and hard, so you cannot bend it, it breaks, and you lose your lateral hinge. You do that under fluoroscopy. Here in that video, it's just putting the pin in. You see posteriorly there's a retractor protecting the neurovascular bundle. You put the pin in, and you check with fluor. As soon as you're satisfied that you like that, then you can commit and do your saw cut. I have a retractor posteriorly, a sponge posteriorly to protect that. Anteriorly, there's a retractor. Personally, and now I come across almost all the way with the saw, both anterior and posterior cortices. But especially if you just get started on this, you might want to do the posterior cortex with an osteotome. It's a little bit safer unless you really know what that feels. So this is just coming across with the saw. And again, I want to hear the sound of the saw hitting the metal retractor, because then I know that I'm in. You might want to take the metal retractor out to check x-ray, but you definitely don't want to cut without anything in the back protecting you, just for safety. And then I completed posteriorly, and especially posterolaterally, you want to make sure that you really split that as far lateral as you can, just to move your hinge point anteriorly rather than posteriorly, and that has something to do with how you influence the posterior slope. And you can make that safe by just putting your index finger on the edge of the osteotome. You know exactly where you are. You protect it from going where it shouldn't go. And it also gives you a reference so that you don't have to floor all the time, because with your finger, you know when you bump up against the fibular head, then you're done. And this is just showing how the osteotome slowly comes across. But if you've done most of the work with the saw, this is a pretty easy part. The only recommendation is get an extra glove, because almost invariably you go through at least one, sometimes two gloves with the edge of the osteotome. You want to open it carefully. Yesterday, both Lars and Tom had mentioned if you if you open it too fast, you can crack the lateral hinge. Well, if you give the bone a little time, you slowly open it up, then the bone can plastically deform rather than crack. So wedge that open slowly. There are different devices to do that. Whether you use these wedges, you got to be a little bit careful, because all the stress is right at the cortex. You can use some wider wedges that more gently open this up across the whole width of the osteotomy, but you do that slowly. And before I even go in with the wedge, just passively, I put a little bit of valgus stress on the knee. I want to see that osteotomy gaps open pretty easily. If it does, then I know that I've done my cuts well. If it really doesn't move much, you don't want to put your wedge in and wail on it. You can get that open for sure, but you don't know what you break in the process. So if it doesn't at least plastically open a little bit, then revisit your osteotomy cuts. Make sure that you've really done a good job with your cuts. You check your alignment, whether you use the Bovie cord or use an alignment rod, doesn't really matter. And then where that weight-bearing line falls just depends on your indication. This is someone who doesn't really have arthritis. He has a focal cartilage defect that we're repairing, so midline is all you need. If this was someone who had more increased medial compartment OA, then you want to shift it a little bit more laterally. In that case, I would go over to probably the lateral tibial spine. You definitely don't want to overcorrect into the lateral compartment, because patients hate how that looks. If someone is all of a sudden in extreme valgus, they're not happy with you. And then how you fix it is really up to you. I use locking plates. You can have small locking plates like these. You can have larger locking plates like the Tomofix that's stable. You can almost immediately weight bear. The rehab after osteotomy has changed dramatically. There used to be a time when we kept patients on crutches, non-weight bearing, for 3 months, and now at least with the larger osteotomy, locking plates, I say for 2 weeks, use your crutches. That's mainly for pain and swelling control. At 2 weeks, do whatever you want to do. Now, if it's a double osteotomy with a tibial tubercle osteotomy or cartilage transplant, then I adjust that. But for an isolated HTO, I let them weight bear as tolerated at 2 weeks. This is an example of a smaller locking plate that also has a calcium phosphate wedge in it. That's load-sharing device, so it increases the stability beyond that what the plate alone can do. These can theoretically be weight-bearing as tolerated from the beginning. And whether you need to bone graft or not, for me it depends a little bit on, is this an at-risk osteotomy, meaning large corrections, smoker, older patient, then I would do autologous bone grafting. As you see here, this is done from, in this case, the medial epicondyle. I did some intra-articular work. You see the medial trochlea here. Using the chisel, you can harvest some cores. You stick that in. I don't do that very often anymore. As Tom had mentioned, allograft usually heals just as well, or these tricalcium phosphate wedges that I showed you previously really helps. This is an example of bone grafting before and after. So with just the plate on, you see empty space, and then after putting these cylinders in, it's filled. Thank you very much. And then, Tom, I think you're next for the DFO, I believe.
I'm going to switch to femoral osteotomies, and let's see, which one will I do first? Let's start with an opening wedge osteotomy, seeing as that tends to be more common these days. So this is just a combined tibial tubercle osteotomy with femoral osteotomy. So what I find frequently in valgus knees is they also have patellofemoral lateral maltracking. And this woman had both knees, both anterior and lateral knee pain. And so when I see that, you really can't correct the maltracking through. So here's what this is just reflection of the tubercle proximally with the extensor mechanism. And now what I'm doing is the guts of the exposure. I go a transverse incision across the top, right there, across the top of the femur. And now now I'm going, okay, so let's just stop for just a sec. Can we just stop it right there? How do we stop? There we go, okay. So what you're looking at, can we just go back a little bit? Okay, good. So the key on the femur is exactly the same as on the tibia, is that you're concerned about the popliteal artery and the perineal nerve. That's the no-no. So what I do is, what I've done here is you can see proximally I've done a tubercle osteotomy. I didn't focus very much on that because this is a film about femoral osteotomy, opening wedge. So, but this woman had valgus knee, maltracking of her patella, and lateral joint pain bilaterally. So what I did was staged her a year apart. And here you can see I've reflected the tubercle, a medial subvastus, a lateral subvastus. So now I have the quads that I haven't touched because I'm underneath the quads. I do supracondylar transverse incision at the top of the trochlea and just reflected the periosteum up. So I make one incision, periosteum here. I make another incision through the periosteum proximally, just above the lateral intramuscular septum, and there's some vessels there, so you got to cauterize those carefully. Then I take this whole sleeve and just reflect it up. So I have a really nice synovial periosteal envelope that at the end of the osteotomy I suture back together, which gives you a beautiful periosteal blood supply to your bone, which is important for healing. Now here on the lateral side, the way to expose the neurovascular structures is at the linea aspera, just where it flips distally, I just take a sharp, I use cautery just to get down to bone, and come along the linea aspera just above the lateral intramuscular septum. And then I just reflect that subperiosteally and posteriorly. I get a small elevator and just go side to side and go all the way to the medial side to the adductor tubercle. So now I'm on bone. And the interesting thing is once you've incised and reflected it here, the dissection posteromedially is entirely blunt with your finger because it's all areolar fatty tissue and it falls off the back of the femur. So then, once that's done, I pack the back of the knee with a wet sponge and a retractor behind it, and then I can go forward with my osteotomy under fluoroscopic control. Okay. Okay. There we go. So I'm just bluntly dissecting with my finger. I'm not using anything sharp. And see that areolar fatty tissue? It just falls away? Yeah. And now I pack it with a small wet sponge. Then I put a retractor on top of it. And here I'm just reflecting distally subperiosteally as well. And I like stay sutures just to keep things out of the way. So now you can see the whole femur. You see that vertical line here I've made? This is really critical for rotation. If you crack your medial cortex, and once you start opening these, it's very easy. And you can see I always have counter pressure on the other side. There's my assistant who's holding the other side. And then these opening wedge tines, as you can see, often I'll start with just a wedge-shaped osteotome to get it opened up a little bit, and then I open it up to where I want. With the other thing that I have right here that you can't see, which is important, is... Where's my thing? Can we stop it again for a second? Why? Where's my arrow? There it is. So it doesn't touch well. That's why. Okay, just as I'm...
You know, if you hit pause down there.
Oh.
And then you can bounce around.
Yeah. This mouse.
It sucks.
It's really bad. Okay.
No offense.
Just before I just move through this, you need to support the distal fragment when you're opening the osteotomy. So what I do is I get a stack of towels and I put it right underneath the knee and hold that distal femur at the level of the proximal femur before I do my opening wedge. Because what can happen is you want to just open it like this, but what happens is it cracks and it flexes. So you flex your distal fragment, and that's a disaster because then you have a rotationally unstable situation. I made my vertical mark before I start opening it, so if that does happen, I know how to derotate it to get my rotation correct. But so right here, that distal fragment is resting in the popliteal space on a stack of towels, so it's collinear. And I don't mind if my knee tibia flexes a little bit out of the way, but that's an easy mistake to make. So I just leave it there, and that gives me a whole lot more control. So as I open my osteotomy, so what I'm doing now is we're just applying, this is a femoral generation 1 non-locking poodoo plate. And you can see I'm just filling it up with, what I do is I crush up cancellous allograft bone and demineralized bone matrix. And then we load up all these discarded oats chisels, which I never throw away. I save them all the time and just separate them and re-sterilize them for every case. And now I just pack, I have a Homan on the back so that I don't push anything through the back of the knee. Once that's filled up, I just reattach that nice sleeve of synovium and periosteum anatomically. And the last thing I do is I replace, all I'm doing here is showing that I always put a little bit of graft on or demineralized bone matrix at the tip where it's cortical, it tends to heal better. And now I'm just filling up, this is underneath the anterolateral muscle compartment with graft on, and here's my lateral lengthening, and I'm just repairing that. And I do it exactly the same way Jack described, where you flip off the iliopatellar band off the iliotibial tract and sew it to the synovium that you've mobilized anteriorly. And that's what that looks like. So that's a combined femoral osteotomy with a tubercle osteotomy, and that's what it looks like post-op. So she was staged a year apart, and you can see she's very pleased. And you see that distal tip of the osteotomy heals quite nicely on the tubercle. Okay. And now can we go to the next osteotomy? Can you just close that out, please? Quit. There we go. Let's go to the closing wedge next. Yep. So closing wedge osteotomy, again here I'm just demonstrating a lateral lengthening. So there's my synovium that I attach at the end. That's how I do the release. And you can see this is tubercle osteotomy again with this one. I'm going to flip the whole thing up. There's the VMO, subvastus on both sides. Okay, now this one was with cartilage transplant. So there's the trochlea, patella, lateral femoral condyle, lateral tibial plateau, but this was a young person. So now I'm just on the medial side of the knee, so I'm going to flip everything medially. Did I? Yeah, I probably did reflect this up. So we're going to debride all these defects, and I think this was done with collagen ACI, so everything was microsutured. This is just demonstrating the areas of damage. And because they're bipolar, I'm looking at anteriorizing it more, so I make my osteotomy steeper on the tubercle as opposed to just slightly oblique. All right, so let's get up to the femoral osteotomy. So this would be done on the opposite side of the knee. I like using that same calibrated jig system that I showed you. It's marketed by Zimmer. I'll use that for my closing wedge because it goes anywhere from 6 degrees to 20 degrees in nice increments. Again, this is just showing the damage on the lateral side and the plateau. And I'll take down the meniscus in order to do that. But we're not going to show you that right now. No, I guess we are. Let's see if I can just move forward. Let's just get to it. Okay, where is? Yeah, I thought this was different. They loaded the unedited version as opposed to, I had them as 1, 2, and 3. Okay, well, we'll get to the, this is, so what I'm doing here is I usually just use a low profile tibial buttress plate for fixation on the medial side of the tibia. So now what I'm just going to do is just go across with the synovium. I'll go transversely from lateral to medial, and then on the medial intermuscular septum proximally, then reflect that entire sleeve proximally, just opposite to what I did on the lateral side. And now we're going to reflect the periosteum out of the way with the synovium. And then, so that'll be taken proximally. Now, to get behind the femur, you need to take down the medial intermuscular septum a little bit at the adductor tubercle. And then it's the same, here we're taking just the anterior synovium off. Okay. And then we're going to take off okay. And now I'm going to the posteromedial corner of the distal femur. And what I'm going to do now, see, you can see, I'm just going to take down the intermuscular septum. Cautery is very effective here. I'm under the adductor tendon right now, yeah. And I'm just going to strip on that posteromedial corner and then put my finger behind it and basically strip it mostly with my finger. It's a little tighter on the medial side getting posteromedial versus on the lateral side going posterolateral. The reason I do closing wedges on the femur still is because some legs are long, and I want to make them more equal in leg length. And the second reason is once I find that, people get over about the age of 50. Their healing time on the femur is slower, especially in women. I will only do a closing wedge distal femoral osteotomy in women because they tend to heal slower once they get middle-aged if they are still candidates for an osteotomy. Okay. Boy, this unedited version's killing me. Hold on. Apologize. Okay. So now what we've done is we've cut across to the other side after protecting the back, and our closing wedge femoral osteotomy jig is on. And so that gets stabilized with a pin. The two distal screws go in first. We just put a pin in. And once that's nice and stable, you can just choose the angle you want and cut to the other side. And then before we're taking the jig, I don't know how this happened. Oh my God. This touchpad doesn't even work. All right. That was too painful. So I take the wedge out, and then I basically just close it with an inverted T-plate is what I do. Now this is a cool osteotomy. So reverse domes I do in patients with corrections of about 15 to 30 degrees, as you can see here. So this is a patient, you can see she's got a windswept deformity and a pelvic obliquity, and you can see these osteophytes on her patella and that valgus knee. We did an MRI scan to show that her medial compartment was intact, and that's critical. This woman was only 40 years old, super active up in northern Maine. And with this obliquity of her pelvis and the fact that she needs something done on the other side, even a total knee wouldn't get her leg lengths back. So here the goal is this is a 20-degree correction. So you put your guide wires parallel to one across the joint, and then this is a 95-degree angled blade plate. And here what we're doing is we're setting our chisel first before we cut the femur. I have this nice little jig system that I have, different radii. Here you can see the one that fits. This is the center of arc of rotation, as Dror Paley calls it. And now I multiply perforate anterior to posterior after I've protected the posterior neurovascular structures with you see there's a home in there and a sponge. And then we multiply perforate it. I have these long, thin Lambot osteotomes now that it's perforated, and I just cut forward anterior to posterior, and then we seat our chisel once the fragment is mobilized. So here we are mobilizing it, and then we rotate it, and once it's rotated and that blade is now almost parallel to the ground, we can seat our blade plate and then clamp it to the femur, and you can get a nice straight leg. And the nice thing about this is when they're healed, first of all, they heal rapidly because they're cancellous bone to cancellous bone, and you've not distorted the appearance of the femur. But the key is to seat the chisel at the angle parallel to the joint that you want to correct. So it will be 10, 15, 20, 30 degrees is your correction, and then you just basically bring the plate in to the sidewall of the lateral cortex, and you have a nicely rotated femur. This one I did a TTO with her as well and flipped it up because I did a debridement of her patellofemoral joint. So she had the same, or did she not? No, did I not do that? Maybe I didn't do that on her. No, I didn't. And I just did a debridement of her patella. But this is what she finally looks like after she's had both her knees done. And you can see it's beautifully healed. It looks like a normal femur. Doing a total knee on that, other than the blade plate being in the way, would be pretty straightforward. You could enter the intermedullary canal right where you want it. And so that's before she had her other side done. And then now you'll see their other side's done as well, I think. Oh, they didn't show. Okay. So that's a reverse dome femoral osteotomy. So anyway, I'm open for questions on that part.
Question about the opening wedge, TFO, but also the HTO.
with the biplanar on the DFO works well for closing wedge, because what happens is if you do your you plan where you do that anterior sliver to the level of the cut that you want to make. I guess now doing it on opening wedge, you'd have to make a really long sleeve to open it that way. I haven't tried that on the lateral side to do an opening wedge, but I have done it on a closing wedge, because you basically make a relatively parallel sleeve, and you can slide it and close it, and you have two surfaces that are thing. I don't know that it provides much extra added stability. It adds a lot more complexity on the femoral side. So I don't really do it too much on the femur, but I find on the tibia it adds a lot of stability. As Andreas said, it helps you to know if you're malrotating it, and it adds to the rapidity of healing, because you have that anterior little sliver that's bone on bone to heal as well. So on the tibia, I do a retrotubercular osteotomy, but on the femur, I tend to just open it and pack it with bone, or close it with a good solid fixation. Yeah, so the question is, what do I do to hold it open while I put my plate on? So what I'm using there is the Pudu plate system. So they have two separate tines. And generally what I'll do is I'll leave the posterior one in. It's designed that you can actually leave the anterior and posterior tine in. But on a femur, usually the femur's not in the AP dimensions, not wide enough to hold both and get the plate on as well. So I'll just leave the posterior tine in after it's open, take the anterior one out, and then put the plate in. And then I use a non-locking plate. What's nice about that is it's very flexible and malleable. So I just get the block in first, one screw on either side of it, get the block seated so I know it's between the cortices. And even if the plate's a little bit off the bone then, it just cinches right down with the screws, and I just use the screws on power. Yeah. Any other questions? Okay. Is that it? Is that our course? We're done. Okay. Well, listen, anybody that stays this long is to be rewarded on a Saturday morning. So thanks, everybody, for coming. We have, it looks like a beautiful sunshiny day in Boston for those of you who are still staying around. And I hope that you take some of the pearls that we've brought to you into your practices. And for the therapists and the nurses, thanks for coming to understand more of what it is that we do to the patients that you then care for and look after. Thank you very much for being here. And hope to see you again in the future. So this course was done for you and for the Cartilage Research Foundation. Cartilage Research Foundation is a group of us around the country. Our goal is research and education, and the funds we raise through meetings like this help support our research projects, our fellows, and doing more of these educational programs. So we're all very grateful to you, and thank you again.